Hey, good afternoon, all. Welcome to Singapore Society for Continence Singapore's GP talk. We are very happy, to have you join us today. And it's 1 o'clock, and we have a very good lineup. But just, for beginning, my colleague Jeff will be sharing the slides with you, and we would like, to thank you all the sponsors to make this happen. Over to you, Jeff. First, a thank you to one of our sponsors, Tina. And our next sponsor,
What do we mean when we say perfection since 1983? In the catheter world, you don't want to cause friction in the urethra, because friction means pain and possible damage, with an increased risk of urinary tract infections. You want a catheter to be as gentle as possible to the urethra. You want a lubricated surface that is smooth at insertion, and you want the surface to stay that way, keeping it as smooth at withdrawal. The trick is to keep the catheter surface perfectly lubricated during the whole process, and here is the big difference. Lowfric's patented urotonic surface technology stays smooth because of its ability to bind water for a
Tina and WellSpec. Next, we have the opening address by our president, Dr. Lim Jit Fong. Dr. Lim, over to you.
Hello, good afternoon, everyone. Can you hear me loud and clear? A very happy 2025 to all of you. Welcome to our GP Symposium for 2025 organized by the Society for Continence Singapore. Today, we have four speakers. The four speakers are Dr. Harvard Lin, Dr. Shirley Bang, Ms. Rachel Tang, and Dr. Sharmini Sivarajah. So they're going to share with us on our theme today, which is about maintaining your pelvic floor health to help our patients age in place. The Society for Continence started in 1991 through a lot of effort by our founding president, Professor Peter Lim. And so it's been more than 30 years running this society. We are a fully volunteer-driven society. We do not have any permanent employees. So I want to thank all the volunteers and all the speakers for giving their time today to share with all of you, the participants, on their topics. Just a little bit of some note first. For all of you, the participants, if you log in order to help us capture your name and MCR number for the doctors as well as for the nurses for your CPE, could you please change your ID on your Zoom to your full name and your MCR number or your CP or your nursing board number? It's to help us make the submission to SMC and nursing board for the points. Thank you very much. So I won't waste much of your time. I want to thank our two sponsors today for today's talk, Tina and WellSpec, for sponsoring all the programs. I'm now going to hand over back to Jeff, and we can start with the first speaker. Would you prefer me to introduce the speakers? Okay, so the first talk will be by Dr. Harvard Lin. Dr. Harvard Lin is a ONG specialist. He is at Gleneagles Hospital. He's in Singapore. He was previously from National University Hospital. His subspecialty interest is in complex gynecological conditions, and he has also a special interest in management of urogynecology, pelvic floor disorders. So I'm going to hand over now to Dr. Harbert Lin to give his talk.
Okay, thank you, Dr. Lim, for the introduction. Let me share my slides now. Okay, my name is Dr. Harbert. I'm a gynae consultant, and as Dr. Lim mentioned, I practice in gynecos. I used to work in National University Hospital, and I see many familiar faces today. So my talk today, since this is a continence society, I focus a bit more on incontinence and my subspecialty, which is urogynecology. Okay. So urinary incontinence is defined as the complaint of any involuntary leakage of urine. So how many kinds of incontinence do we know of? The first, which is the most common, is urge incontinence, which is the symptom where you feel sudden urge in time and the urine just leaks out. All right. Second is stress incontinence. It's a condition where when you cough or when you sneeze or when there's any increase in abdominal pressure, urine leaks out. All right. Next is overflow incontinence, where most patients who have some form of obstruction or bladder dysfunction, there's a lot of urine inside the bladder, so much that it just leaks out. And the last is true incontinence, which is usually a surgical complication, a fistula formation or some connection between the bladder and the vagina where the urine just leaks. Okay, so my focus today is more on the first two, which is the main two conditions which you will see in your practice. So overactive bladder, by definition, you will definitely see this in almost all your patients that are menopause, female patients. Okay. Definition is the symptom of urgency. Usually it is either daytime frequency, nighttime we call it nocturia, the number of times you go to the toilet, and sometimes with or without incontinence. Okay. The patient will say that they typically they are in the shopping center, they want to go to the toilet, but there's a long queue. So the urine just leaks out before they make it to the toilet. Sometimes when you're going home, you feel very urgent, you are opening the door. Before you make it to the toilet bowl, your urine leaks out. That is a symptom of overactive bladder, which is very common. Okay, but the symptoms are quite similar to many other conditions. Most of them urological conditions, which Dr. Bang will speak about. Okay, urinary tract infection, which she's going to talk about vaccination to reduce the risk, tumor, stones, surgery, and very commonly in menopausal women. Okay. So what causes overactive bladder? Your kidneys produce urine, right? And the urine drains into the bladder, and the bladder's function is to hold the urine. The urine then passes out through the urethra. So the problem is in the third step, where the bladder is unable to hold the urine. Okay. So how do we define it? It's hard to ask a patient how many times they go to the toilet in a day. They probably can't remember. So usually ballpark, I will ask them, do you go to the toilet more than once an hour? Okay, or do you wake up at night more than 2 times? So if you have these two symptoms, your bladder is more or less a bit more active than usual. Okay. Now, it is only necessary to treat if this is bothering the patient. So some patients, example, they are retired, they are staying at home most of the time, they hardly go out, it's not bothering them, we don't have to do anything. But for some professions where, example, taxi drivers or those that are in the sales position, they cannot keep going to toilet. All right. Urgency is defined by a sudden, strong desire to urinate. You cannot, it's so uncomfortable that you have to find a toilet. Okay, and we definitely see a lot of this in our own relatives. And sometimes it's so bad that the urine just leaks out involuntarily. So in NUH and in our practice, we usually have questionnaire for the patients to fill. On the left is the history. and on the right is examination. Okay, so we go through quite systematically. You can ask the slides from our organizers. To me, the most important thing is, do they feel embarrassed by the condition? Because if they leak urine and if the pants smell, or if they have to keep going to the toilet, they feel at workplace people are judging them, they feel embarrassed. And secondly, does it affect their way of living? If they say yes to these two, then yes, I think we need to look into the issue and sometimes treat them. And a lot of patients actually think that it is part of aging, it is part of their lives, and they don't really address this problem. So once in a while, you see an older patient, you can actually ask them in a history. Okay, and most of them will say they do have some form of incontinence. So what can we do to, as a workup, when they say they have frequency, they have nocturia? Okay. First thing, in the GP level, what we can do is we can do a dipstick to make sure there's no infection. Look for white blood cells, look for nitrites. If we are suspicious, we can send for urine culture. Second thing that you can do is to palpate the abdomen. You remember when I first told you incontinence, there are 4 different kinds. So sometimes it could be overflow incontinence. That could be the cause of this leakage. So what we can, I mean, some clinics may not have an ultrasound scan available. So you can actually try to palpate, especially in slim patients. If the bladder is very full, sometimes it is palpable. Okay, so a palpation to make sure it is not an overflow incontinence. Okay. Now, I mean, in medical school, we all learn about a urodynamic study, right? Urodynamic study. To be honest, in private practice, we don't do it very frequently. Okay, it is more an academic need. Okay, a urodynamic study is important if we can't tell what is the problem. We can't tell whether the incontinence is because of stress or because of overactivity. Sometimes we can't tell. We do it usually only as a pre-operative workup. So at the primary level, not necessary. Okay, we can always treat first. We can always have some form of conservative management first. This is a bladder diary. Okay, I find a bladder diary very useful because sometimes patients, they are drinking excessively, which they do not know. Okay, or sometimes their urination is not as bad as what they describe. All right, so a diary tells us their practice, what kind of fluid they're drinking, and the frequency and volume of which they are drinking. And sometimes we pick up certain conditions like diabetes insipidus from this because we see that they're producing more fluid than they consume. Okay. Okay, so what causes overactive bladder? Detrusor activity is not exactly the same thing, but the condition where the bladder contracts excessively, we call it detrusor overactivity. So what causes it? The bladder is controlled by the brain, a higher center control. So when you're in the toilet, when you're ready to pass urine, the brain will control the bladder to contract. The brain will tell the sphincter to relax so that the pee comes out, right? Now, detrusor overactivity is when there's no more of this control. It means the bladder will contract on its own without any reason. Okay. Usually there's some form of provocation, either movement, change in posture, and sometimes even the hearing running water. Anybody knows why hearing running water causes urgency? You remember when you're young, when you're a child, when your parents ask you to pee, they always make the running water sound, right? They do this, correct? So from young, your brain has been tuned that whenever they hear running water, is to relax the bladder, is to relax the sphincter, to pee. So this is ingrained in the brains. So after some time, when you start to lose control, it becomes subconscious. When you hear running water, you begin to feel urgency. Okay? So how do we manage this condition in the primary setting? We first look at the lifestyle, as I said, from the bladder diary. Is the patient drinking excessively? We can counsel them just to limit the number of carbs they drink only to thirst. We look at the diet, a lot of spicy food, a lot of acidic food. We look at the kind of fluids that they are taking, too much caffeine, too much coffee, of course. Things like Coke, tea also has caffeine, and also they can cause a lot of diuresis. Okay. Sometimes anxiety, you can imagine when we used to take our exams, we want to go to toilet before we enter the hall, right? So anxiety tends to make the bladder more sensitive. Stress or habit. Some people just they feel like they want to go toilet every time they have the chance to, so much so that the bladder no longer has the ability to fill up. Okay. Sometimes medication, medical conditions like diabetes, or some form of stones, as I mentioned, stones, tumors in the bladder. This is a list of differential diagnosis that can contribute towards an overactive bladder. All right. So how can you counsel your patients? First is to lose weight. Okay, being obese sometimes can cause the bladder to be more active, can cause increased abdominal pressure. Regular exercise, physical activity, strengthening of the pelvic floor, which I'll talk a bit about later, limiting caffeine and alcohol, quitting smoking, which triggers the bladder, and managing their chronic conditions. If you look at the Ayuga website, which I think is a very good source of information for, even in my practice, and a lot of information for family practice as well. There's one guidelines on bladder training. Okay, do you teach your patients bladder training? So imagine the bladder is like a balloon. Okay, you ask the patient, the moment they feel like they want to pee, they squeeze the pelvic floor and they don't go to toilet. Let the bladder fill up a bit more, maybe 5 minutes more, maybe 10 minutes more. And then do that every time they want to pee. So hopefully after time, the bladder starts to fill up a bit more. It regains its elasticity and they start to be able to store a bit more urine. Okay. Second thing is pelvic floor exercise, which is a bit more important in stress incontinence, which I will explain again later. But why pelvic floor exercise in overactive bladder? So briefly, you tell the patient to squeeze the pelvic floor. How do they understand this? You imagine you're passing urine. As the urine is about to flow, is flowing, you squeeze the pelvic floor so tight that the urine stops flowing. That action. So ask your patients to squeeze every morning, afternoon, evening, as many times as they can. As they are watching TV, as they're waiting for the bus, they keep squeezing. The pelvic floor muscles will strengthen and gives them some form of control. So what they can do is, especially for those patients with urge incontinence, as they feel very urgent, they want to go to the toilet, they can squeeze the pelvic floor on the way to the toilet so that it can stop the urine from leaking out in that process. Okay. Scheduled toilet trips is not allowing the bladder to get too full. So rather than go only when you feel so urgent, maybe you can go every 2 hours. All right. And medication. Okay. So I'll talk a little bit more about medication. The main form of treatment is anti-muscarinic or anticholinergic drugs. Okay. So I'm not sure if you have this in your clinics, but the mode of action is at the acetylcholine receptors, which is the nerve fibers connecting the nerves to the bladder. Okay, if you remember this in pharmacology, the bladder has muscarinic receptors. All right, and the nerve will release acetylcholine to trigger the receptors so that it starts to contract. All right, so the medication acts in this level as a block, so it doesn't let the acetylcholine trigger the bladder. Now you can imagine when you give this medication, this is a very common receptor, right? So it's present in many other parts of the body. So you can imagine when you give this medication, you need to warn your patients of the possible side effects. All right. This receptor is also present in the eyes. So sometimes they may get eye dryness. The most common complaint that I hear of is usually mouth dryness. Okay, and some patients actually, they stop taking the medication because of the mouth dryness. Okay, they can cause palpitations, they can cause constipation, they can cause gastric retention, bloated feeling. And in patients with a weak bladder, they may get urinary retention. That's why one of the examination I think is important at the start is to make sure they don't have an overfull bladder. Because if you give this medication, they may end up with the bladder being unable, acute retention of urine. All right. So some of the options that we have in our in the hospitals as well as in the clinic is oxybutylin, ditrusitol. The most common is ditrusitol and vesicare. These are the three most common medications we give. Oxybutylin is one of the earliest drugs. The problem with oxybutylin is the side effect profile is one of the worst. So it's the worst mouth dryness, but it's the cheapest. So if you want to store something that is cheap and effective, is oxybutylin. Okay, ditrusitol and vesicare are the newer generation. So the effectiveness compared to oxybutylin is the same. Actually, studies show that they are about the same. The only difference is the rate of the side effects are much less. All right. So for patients who have nocturia, specifically nocturia, sometimes we give a bit of antidepressants. Okay, we can give either imipramine or amitriptyline that can help to relax the bladder. All right. And the last medication, which not commonly given, is antidiuretic hormone. You basically, the medication stops the kidneys from producing urine. Okay. Why not commonly given is because the effectiveness is very short, about 30 minutes, about a couple of hours. And once the drug effect wears out, you will have a rebound in terms of urine production. So it doesn't really solve the problem. It's good for patients who need continence for that period of time. For example, watching a movie or going on a trip to a road trip or doing an important meeting. Okay, but it's not a long-term solution. Okay, so that is urge incontinence. So importantly, you need to know the difference between urge incontinence and stress incontinence because the treatment is different. Okay, so what is stress incontinence? When you cough, when you sneeze, you leak urine. Okay, and it's due to the increase in abdominal pressure. So why does this happen? You imagine under the bladder, you have a pelvic floor. Okay. The pelvic floor supports the bladder, the rectum, and the urethra. So the pelvic floor is like a hammock, like the girl is sleeping on the hammock. So the pelvic floor can get damaged when during childbirth, can get damaged during surgery, can get damaged when we use a forceps to pull the baby out. Okay, the damage can happen in the center and can happen on the side. So this bowl can be broken this way, or it can be broken this way. It can open this way. All right. So the support is weak. What happens is, you imagine when you are passing urine, your urethra is resting on this support. So if the support is weak, there's nothing firm below the urethra. When you cough, the urine leaks out. But when this support is strong, when you cough, it presses on the urethra and it closes up. So the urine doesn't leak out that much. So problem is with stress incontinence is almost always a problem with the pelvic floor support. So how do you get it first? We go back to what happened before. Majority of the time is a patient who had a child before, normal vaginal delivery. Majority of the time. So if a patient who is nulliparous or that haven't got pregnant before or haven't had intercourse before and tells you she has incontinence, and from coughing, I get a bit, we need to pay a bit more attention to the history because not common. Doesn't mean it doesn't happen, but it's not common. If you're having a vaginal delivery, especially in patients that had an instrumental delivery, so you can say if you had a vacuum or you had a forceps, it tends to worsen. Genetic causes, sometimes you can ask the patient to look at the ligaments. If it's extremely lax, they might have a ligamental issue. Okay. And of course, menopause and aging. So some patients, I had a patient who is totally no children, but she has chronic cough, asthma. So she's coughing all the time for 20, 30 years. And every time she has to cough very hard to get her phlegm to come out. So every time she does that, it stresses the pelvic floor. So over time, it gets damaged. And that can cause stress incontinence. So age, if you can look at these two pictures, the top picture, the top diagram is a diagram of a vagina that is premenopausal, 30, 40 years old lady. The bottom is a picture of a vagina that has menopause, a woman that has menopause, 60, 70 years old. If you do a speculum, you can notice the difference because the menopausal vagina is very pale, is very dry and thin. Similarly, in the urethra also gets thinner and less, more sensitive. So you can see that the lumen is wider. So the risk of leaking gets much higher as well. Okay. So what else can stress the pelvic floor? Again, your weight. Okay, weight is one of the biggest stressors on the pelvic floor because it's constantly stressing the bottom. So obesity, if you can lose weight, a lot of patients actually stop leaking. So what can you teach your patients? Remember earlier on in overactive bladder, I talked a bit about Kegels exercise. Okay, the squeezing action, done in a very regular fashion, 50 to 70% of patients will get some form of cure. May not be totally dry, but they will feel some form of improvement. If it takes a lot of time to counsel the patient, sometimes we recommend physiotherapists to do the counseling because they have more time and they have more resources to look at the effectiveness of the way the woman is squeezing a pelvic floor. Okay, but Kegels exercise is one of the best ways to treat this condition without any intervention. But sometimes it doesn't work. Okay, imagine when the entire hammock is already broken off the bone. No matter how much exercise you do, it is still lax, right? So what we can do is surgery. Okay. If the pelvic floor is no longer working, sometimes we put a artificial tape under the urethra to support the urethra. So there's no more support from the pelvic floor. We can put an artificial tape. This tape can either come out from the abdomen or come out from the from the groin. There are many different methods we can use to strengthen the pelvic floor. Excuse me. But usually we try with our conservative methods first because it is free. Okay, patient can do it all the time. Something else which primary practice can adopt, which I think is not very commonly done, but I think is a very good thing that you can do, is to give patients some form of vaginal estrogen. I'm not sure if you have it in your clinic. It's something good to because vaginal estrogens are very safe. They hardly go into the system, and they help the pelvic floor to get more vascular, to get a bit more thickness. So a lot of patients with estrogen and with exercise, they actually are cured of incontinence, and the overactive bladder gets better as well. Okay? So this is incontinence. Now, prolapse. I'll just touch very briefly about prolapse, just to make everything complete. All right. This is an example of prolapse. There are many different grading of prolapse, but not important to know in the family practice. What kind of condition do you need to refer a patient? Okay, I think always a dilemma is, when do we refer a patient? Prolapse is a very common condition. If you have any patient who had a vaginal delivery before, if you examine them in detail, you would see some form of prolapse. Either the uterus is coming downwards, the bladder is dropping down, or the rectum is protruding upwards. Either way, some form of weakness will be seen. Okay? Majority of them don't need anything to be done. So when do we refer. So two conditions. First, when they say that they have difficulty passing urine, okay, they need to push the prolapse inside, they need to change the position, they need to have a Valsalva force before the urine comes out, not good. So first is you ask them for this. Second is it's bothering them. Sometimes the prolapse that comes out affects the way they walk, is very uncomfortable, can't have intercourse, or is getting painful. Okay. In some rare conditions, the prolapse can cause recurrent urine tract infection. So a patient that keeps coming back to see you for infection, UTI, if you do an examination and they have something protruding outwards, is another indication to refer, because this patient probably needs some form of intervention. Understand? Okay. So what can we do? Firstly, we can put a pessary. Okay, we can push the prolapse inside and put a pessary to keep it in so that it doesn't come out. All right. Pessaries may be a bit troublesome sometimes because the patient have to come back every week, every 2-3 months for a pessary change and to check the inside. So sometimes we do a surgery. Okay, there are many different kinds of surgery, but most of the time we remove the womb and we strengthen the pelvic floor from a surgery done in the vagina. All right. So when any patient asks you what kind of surgery it is, you can tell patient the surgeries are usually done through the vagina without any abdominal incision. Okay. My last few slides just to go through certain things to look out for. Okay, some patients who have given birth, I go the third and fourth condition of incontinence, which I mentioned initially, right? If they come to tell you they can't pee, so what are the main problems? Firstly, look for any form of obstruction. Can be hematoma, can be stone, or can be a tumor. Okay. Secondly, look for any functional problem. Sometimes suddenly the bladder doesn't contract anymore. All right. Because of this condition, sometimes the urine leak out. What can you do in the family practice? The first thing is you can relieve them of their condition by putting a catheter inside, so they feel much more comfortable. All right. If they have very bad inflammation in the pelvic, which is causing a lot of pain, you can give them some anti-inflammation NSAIDs to reduce the pain, or some cream. Okay, I have a patient that had herpes before. Have you seen herpes? Quite common in the practice. It's very painful. It's like multiple ulcers in the vagina. Because of the pain, they squeeze the pelvic floor so bad that the urine doesn't come out. So even they go to the toilet, because of the fear of the pain, they squeeze the pelvic floor until they have ARU. So sometimes the IDC will help this condition. Okay. Okay, and last, true incontinence, something we don't want to see because usually it is difficult to treat. There's an abnormal tract between the bladder and the vagina, usually from surgical complication. Sometimes it can happen from conditions like inflammatory bowel disease or radiotherapy. Okay, so if a patient says the urine does keep leaking out, even they are not coughing, they are not urgent, when they're sitting, they're standing, the urine does leak out, we be a bit more careful because sometimes it can be a fistula that's formed. Okay, very rare condition though. Okay, I come to the end. I hope that I give you a bit more information on how to manage incontinence and what are some of the measures that we can do at a primary setting, which can be done. I think a lot can be done in a primary setting, and follow-up can be done as well. Of course, any patients that do not work, like your anticholinergics don't work, or the pelvic floor exercise doesn't work, you can always refer them to us, or you can refer them to a urologist. Okay, my last slide is my family. So I'm married with 3 kids. My biggest is 12 years old this year. Stressful year for me. Okay. I think the questions are at the end of the session, right?
Yes, the Q&A is at the end of the session. Thank you.
Okay, 1:35, just right.
Thank you, Dr. Lin. Let's actually put our hands together and thank Dr. Lin. And next we have is Dr. Shirley Bang. So let's welcome Dr. Shirley Bang. And Dr. Shirley, it's a Singapore Medical Council certified urological specialist. Prior to her current practice, she was a full-time consultant at Tan Tock Seng Hospital. Dr. Shirley's subspecialty interest is in the treatment of urinary incontinence, overactive bladder, OAB, and neurogenic bladder, as well as functional and reconstructive surgery, of the urinary system. Let me not waste any more time and let me hand over to Dr. Shirley Bang. Over to you, Dr. Bang.
Hello, hi, thanks. Can you hear me?
Yes, I can.
Yes, can. Okay, so thank you for inviting me. Can you see the slides?
Yes, I
Can
can.
see, everyone can see, right? Okay, so I'll just start. So I will talk about one of the most common and actually quite difficult to manage condition in the primary care as well as for urologists. Even though it's not perceived as a very serious condition like cancer, but it takes up a lot of our time, and I'm sure the GPs as well, and also causing a lot of frustration for the patients. Okay, so I think we'll start with the standard definition to remind everybody that the definition of recurrent UTI, or I'll be using the short form throughout the talk, rUTI, is defined as 2 infections in 6 months or at least 3 infections in 1 year. This one including both upper and lower tract infection, and they should be confirmed by positive urine culture. So these are some of the risk factors in recurrent UTI. So I actually divide it into the young and the premenopausal ladies, and then versus the post-menopausal. So no need to read all this. Actually, the most common reason for recurrent UTI in premenopausal lady almost always it's either due to not enough water drinking, habitual holding of bladder because of work, or also very commonly in sexual intercourse. Then the postmenopausal lady is usually because of menopausal changes. And of course, some patients, they are higher risk in getting a recurrent UTI compared to the rest. And usually there's a family history in this kind of condition. Okay, so what can be done at the primary care level if you don't suspect any urological conditions? So I think most importantly is I always identify the risk factor for in this condition, rather than every time they come and then you dipstick and then give antibiotics, because that's the most commonly done. But if you want to maybe prolong the visits of these women, then maybe we try to identify the risk factors. Either is it they don't drink enough water, which is actually very common. Holding bladder, is it after intercourse? Is it because they are too clean? They clean the perineum, they clean the urethra with vaginal douching or feminine wash or soap. So simple things that you can advise them, that you just drink more water, you don't do all this, you avoid your risk factor, then you don't get your UTI. So then when do I refer to urologists is that if I try behavioral modification for some time and then it's not working, or recurrent pyelonephritis. But actually, if the patient have pyelonephritis is considered complicated UTI, then you can refer to urologist already. Then complicated UTI in pregnant women, or the patient has urological conditions or some reconstructed urological conditions, diabetes, long-term IDC, or multi-resistant, that you don't have the oral antibiotics available, that you need, OPAD. So also can refer to us. Then, so when the patients come to our clinic, what do we do is that actually we would very, if we see a urine test results or even some kind of imaging of the kidneys and bladder, we are very happy because, wow, it saves like half of the consultation. But essentially, we want urine tests, the proper lab urine and urine culture. And then if there's no upper tract imaging, then we'll just quickly do a bedside ultrasound of the kidneys and the bladder. Sometimes, depending on the symptoms, we will do a flow test. Then depending on the severity or the suspicion. So further investigations like CT scan or scope, we may offer the patient, but not always, because usually we don't yield anything serious. Okay, so what do we do for these straightforward recurrent UTI patient? I always believe in prevention, because actually recurrent means we want to prevent it from recurring. So prevention is very important. So number one, if there's acute infection, I'll treat the infection until I get a negative urine analysis and culture. Sometimes we do have to refer to ID for IV antibiotics. And then for prevention, I actually subdivided into non-antimicrobial, which is non-antibiotics. So you can see we have so many things to play with in the non-antimicrobial section before we move to antibiotics. Okay, so I think cranberry is very, very important. Yeah, so most patients, they will drink the juice, eat the fruit and all these things. So I'll tell them that we actually need to take the supplement because we need the active ingredient of cranberry to prevent attachment of mainly E. coli to the wall of the bladder. So we need the tablet rather than the juice or the fruits. Okay, then probiotics also I find is also very important, because why some patients are more at risk of getting UTI, or if you are traveling a lot, different countries, and you tend to get more UTI because the changes in our flora. Also, same reason why some ladies, if they change relationship or more active intercourse or unprotected, they get more frequent UTI, also because the vaginal flora is disturbed. So if it's disturbed, then we need additional help to restore back the probiotics and our pH. So some of them might be taking the general probiotics. Then I'll tell them that we need vaginal probiotics. There are specific strains that they isolate to help with recurrent UTI. Okay, so how they work is that basically by acidification of mucosal surface, because this is our healthy pH, then they will inhibit the adhesions of the pathogens. Okay. So then usually the most common question is that I already been taking some that I buy online or from Guardian. So I'll tell them that you can show me, and I'll just make sure that the strains of the probiotics is the correct one. If they are not so sure, then usually I'll just give from my clinic, or I'll tell them the brands that they can go and take. So essentially we need these two important probiotics, and we need no less than 10 to the power 8 of CFU per ml. So this is different from the general probiotics for gut. And usually they will have cranberry inside. So it's good to take 2 capsules every night. So then there's this urinary antiseptic medications that some of my patients do take and find it useful. But most of the studies are effective as a short-term prevention. In Singapore, we don't have this. If you need to bring this in, it will be under the HSA monitoring. So you can't get it prescription, you can't get it at Guardian, all these things. So some of the urologists, we have this, but not so commonly used. So that's why some of my patients actually buy this online. Okay, then there is this other option, endovesical instillation. That means when we instill medication directly into the bladder. So the instillation basically consists of hyaluronic acid and chondroitin sulfate. It's essentially to restore the gag layer of the wall of the bladder. It's usually used in interstitial cystitis or radiation cystitis. Normally, this option I offer to patients if they have a lot of damage to the wall of the mucosa of the bladder, meaning that they will have gone for some kind of cystoscopy. If I see the wall is damaged, a lot of inflammation, then I offer them this treatment. So the installation is very easy, so very, very short catheter. So once we instill, they keep it in the bladder for about 2 hours, and then we do this once a week for 6 weeks. Yeah, so it's to help to restore it. Hopefully, it will prevent the recurrent inflammation to the damaged wall. Okay, then for postmenopausal lady, actually vaginal estrogen is quite important because they will tell you that they feel very dry and very irritative in the vaginal area. And then if they keep passing urine, because they also have overreactive bladder, so they will keep passing urine and they'll irritate the area. And then that's how they'll end up with UTI. So can try a topical vaginal cream. Some patients have this misconception that it's not good for them because it's a hormone, but it's like what Dr. Lin mentioned, it's low risk and it's topical. So please reassure them that it's okay. Except for some patients with risk factor like cervical cancer or this, then I try not to give them the medication. Okay, so of course we come to the gist of the talk, which is the latest development in recurrent UTI with the oral vaccine. So what we have now in the market, or some of us, is the two most common, the OM89 or Urovaxum or MV140 Euromune. So essentially how they work is by activation of our mucosal immune responses, so that there's this crosstalk and homing of immune cells between the mucosa of the oral cavity, the GI tract and the urinary tract. So they were supposed to neutralize the pathogen before it causes infection. And the sublingual approach, which is the Euromune, appears to be more superior nowadays. So very, very mild and very non-specific side effects. Almost none of them complain of any significant side effects. So if I start with the first one, which is Urovaxin. So Urovaxin has the longest history. So it's an immunostimulant and basically consists of 18 strains of E. coli. So it's specifically for E. coli UTI. So we prescribe 1 capsule a day for 3 months, and then we have a booster dose and all this for from month 6 to month 9. So most trials actually favor Urovaxin, although they are quite low quality and usually limited for the first 6 months. So how do I tell patients is that usually this group of patients, they will have tried everything, and they most of them are quite really frustrated and desperate, and they don't want to resort to antibiotics. Then I will offer them to try oral vaccine. But I'm quite strict in the sense that I would want to have at least 1 positive urine culture proven UTI. So I'll tell them that you can try this, minimal side effects, and then we will just see. Of course, most of the studies is in 6 months, 9 months, but we'll see different individual. So most of them are very open to this. Then, of course, we have the Euromune, which consists of 4 strains of heat-inactivated uropathogens, the E. coli, Klebsiella pneumoniae, Enterococcus, and Proteus vulgaris. Proteus vulgaris not so common in the local context. It's mainly E. coli and Klebsiella. So under the tongue spray, also two spray once a day for 3 months. So the evidence for this is more contemporary. The research studies of higher quality compared to Urovaxin. So higher percentage of patients achieve UTI free at 9 months. So if I see the patients with more different bacteria causing different episodes of UTI, then usually I'll offer them Euromune instead of Urovaxin. So this is also another vaccines to consider. Then we have other things, for vaginal delivery of vaccine, and you have others as well. So these, we don't have it here yet, and because they are still ongoing research studies, so we mainly use the first 2 for now. Okay, so we have challenges facing this kind of UTI vaccination, mainly the regulatory side of things. So because UTIs are low mortality and they already have very well established and effective treatment, which is antibiotics. So they are not very important, like I say, very not important disease like cancer and all these things. So not many of us willing to apply to HSA and bring in this kind of oral vaccines, not because it is not important, it's just a very tedious process actually. So, and also there are many unanswered questions like, do we give booster? What's the schedule? What is the effectiveness in the long-term wise and all that? So I always have open conversation with these patients, and I try all conservative management before I try oral vaccine. But definitely is a new hope for this group of patients. And some of the practical consideration for oral vaccine is that for Singapore, we need to bring in these vaccines under special access route under HSA and on a named patient basis. So they are monitoring, and almost all insurance will not pay for the oral vaccine. So it is self-pay, and so all these things you have to explain to the patient. Okay, then we come to the conventional prevention, which is antibiotics. Three different kinds of prevention. One, the self-start regime, I wouldn't consider as a prevention. It's more like some patients, they don't mind keeping standby antibiotics and they feel it, then they will start antibiotics on their own. So these patients, they are usually quite experienced and they know their symptoms. So I will give them antibiotics for standby. The post-intercourse self-start, I find that for antibiotics prevention, the number 2 is the most effective if they are very, very sure that it's almost always due to intercourse. Then after intercourse, I'll ask them to take cefalexin 250 milligrams or nitrofurantoin. Usually I'll give cefalexin because it's more well tolerated compared to nitrofurantoin. So if you ask and it's always intercourse, I think just try the after intercourse prevention. Almost always work. Then at least you break the cycle for them. Then there's this low dose long-term antibiotics, 3 or 6 months, also works. The problem is that after they stop, it will come back. Yeah, so sometimes I do give it to patient also for them to break the cycle, and then, so that they can take their probiotics, their cranberry, and then de-stress and all that. Then they will stop, and then we see how it goes. Okay, so these 3 different kinds of antibiotics prevention. Okay, so I think my personal take-home messages is that when the patients come, and I really spend long time to understand what are the triggers. Sometimes even have to sit here and chit-chat and all that. Then you know that they have triggers, either their diet, their lifestyle, stress level. Usually the kids, like what Dr. Lin mentioned, PSLE and all that, then they'll suddenly become very stressed and the immunity drop, and then they keep getting UTI and all this. So yeah, so I really talk to them. If it is after intercourse, I think this is the easiest to manage. I will tell them that maybe you try to go protected sex, it will lower the risk, and then I'll always give 1 dose prevention antibiotics. Then other kinds of behavioral modification, I'll talk to them. Sometimes a lot of things is not on the book. Is either personal experience or other friends, you just share with them. Then if they understand the concept and then they understand what triggers, they actually can self-manage quite well. So, but if we go with evidence, then the most basic, I'll always start with behavioral change. I'll always give probiotics cranberry supplement. Then if still is not working, I'll offer antibiotics. I think post-intercourse is the most useful. If they have cystoscopy or they've go for cystoscopy and there's a lot of inflammation or damage to the mucosa, I will offer endovesical instillation and oral vaccine, basically the last resort. I think this is my last slide. Yeah, that's it.
Thank you, Dr.
Yeah.
Bang. Thanks a lot. What we will do next is that we're just going to show you the 2 videos from our sponsors, because all this is happening because of the kind sponsorship from Tina as well as WellSpec. So over to you, Jeff, to share the 2 videos. And meanwhile, while the video is screening, do check out on the chat box. There is the QR code there. If you come in late,
What do we catheter doesn't stick at withdrawal. It's the key to less urethral trauma and urinary tract infections. And low-fric catheters have strong medical evidence to support long-term health. In short, low-fric's smooth surface has prevented pain and urinary tract infections for 40 years, and that is something to celebrate.
Thank you. Next, we have Rachel. Let me, bring Rachel up, spotlight for everyone. Here we have Rachel. Rachel Tang started her physiotherapy career covering various sports teams and events before eventually settling, in one of Singapore's Tan Tock Seng Major Acute Hospital for 11 years. Rachel is now in private practice and she headed the hospital's she's actually with Singapore Allied Health Professional Council and is a member of the Singapore Physiotherapy Association and a voluntary board member of Society for Continence Singapore. Over to you, Rachel, for taking this afternoon to share with us. Yes.
Okay, Ken, thank you. Hi, everybody. Can you see my screen? Is it up? And can you hear me?
Yes, it's good. It's good and it's clear.
Perfect,
Thank you.
Perfect. Okay. So thank you, Jenny, for the very nice introduction. So I think just a quick summary about me is that I have been in specifically this line quite consistently since 2015. And today we'll be covering a little bit about what Dr. Lin had discussed, which is a little bit more about management. And we're talking about physiotherapy management, specifically pelvic floor therapy and staying active for incontinence prevention. So this actually talk will cover two different things, which is pretty much for those that haven't had incontinence but want to continue not having incontinence, and then for those that do have a little bit of incontinence already, what are some things that you can already start to kind of look at, think about, as well as start patients doing at the sort of the primary care management stage. So the objective today pretty much is what is the pelvic floor and its role in continence, how to stay active, and what do we actually tell our patients when they come in and they ask you, oh, okay, exercise more. But what do you mean by exercise more? What do you need me to do? How often do I need to do it? And what do I need to do to get the benefits? So we're going to cover a little bit more specifically that, which is things that you can use immediately in clinic tomorrow. And also tips and tricks for those that are already showing signs of incontinence. So all these things can be done at the primary stage. So for those who are not so familiar with this particular area, if you can actually look at both the male and female pelvic floor musculature. So the male obviously is on the left, the female is on the right. So if you look at the colors, they actually look exactly the same because musculature-wise, is really, really very similar. The main thing that is actually different, of course, is that the men don't have vagina. So there's like extra one outlet for females. And also, if you look at the pink color, you actually look at the bulbospongiosus muscle, it actually is longer in the men. So that muscle actually tracks all the way from the cavity, the urogenital cavity, all the way up and further on past the scrotum. So if you have people that have pain and tenderness and tightness around that region, it not necessarily is the prostate. It sometimes can really be the muscle because that's directly where it is at. Okay, so it's quite nice to see that same, but a little different. So then what's the importance of this big muscle here? So we actually have a lot of roles. It's a muscle, I would say that pelvic floor is a little bit like wives. So pretty much they have many little roles. Some times they play more in one part, sometimes they play in the other part, and a lot of times they are multitasking all over the place. So the main things today that we're going to be talking about actually is the sphincteric function, the pelvic organ function, as well as pretty much the stability function, which is, we're talking about like prolapse and things. The lesser known sort of functions are actually sexual function, as well as sump pump, which is for those that have venous varicose veins within the pelvis. Okay. So this is what I was talking about. We're going to cover the small ones first and talk a little bit more about the next bigger function. So the sump pump pretty much is the pelvic floor is the pump, just like our calf muscles of our pelvic veins. So some patients actually, especially looking at post-pregnancy or for patients with varicocele, those are more familiar terms that we would hear if they have like a venous leak or venous congestion. So the pelvic floor is actually important to maintain that sort of pump. If it's not working well, of course, the veins are dilated, you will have issues in this area. So then the second, not so commonly talked about, but a lot on social media, is actually sexual function. So for men, remember you saw the bulbospongiosus muscle, that actually plays a very big part in the sexual function in erection. And then for females, it's more of the relaxation component, but having that actual strength also helps to have clitoral erection. So similar functions, but the females need a little bit more of that relaxation component to allow for painless penetration. Thirdly, this one is more like for physios. We love all this part because of the breathing and the posture. But I think the main thing you want to remember is actually the pictures on the left, where you see if a person inhales, you will actually, or you can try now, you put your hand on your belly. If you inhale, take a big breath, you'll feel your belly coming out, and the pelvic floor muscles should come down. When you exhale, the diaphragm comes up, the pelvic floor also comes up. So for certain people who they're already overloaded, they have back pain, they have urinary incontinence, or they had some of them even like surgeries within the lung, they're coughing a lot, you can actually cause a lot of issues because this muscle is like triple tasking instead of multitasking, doing many, many different things at the same time. Sometimes it just gets tired. So just now we're talking about prolapse, and Dr. Lin was also mentioning how the pelvic floor actually supports and is the active structures that help to maintain. So I would like to maybe just clarify a little bit where the ligamentous support, you're talking about the bladder, uterosacral ligaments, as well as our bowels. So those things the pelvic floor doesn't do. But what the pelvic floor does is that if there is a disruption within sort of the organs and things are kind of descending down, it can help to lift from the bottom. So if patients do ask you, actually it doesn't make sense. If I have pelvic organ collapse is coming out, how does strengthening the bottom actually help? So yes, it will not raise, but it does help to support. So that's one. For those that don't have such severe cases, the pelvic floor actually does help to prevent further sag. Because if you think about it from the bottom and you have sort of that hanging on the top, if you don't have support from the bottom, this is always hanging low. You end up with a very long stretch of your bladder, long stretch of the uterus. These two, definitely pelvic floor has had evidence to help to support or prevent worsening as well as to manage symptoms. It doesn't apply so much for our back passage. You're talking about rectoceles, because in terms of how much support you get from the pelvic floor, it doesn't work as well. So I would say for those with anterior as well as central pelvic floor does help support those that are not as symptomatic. You don't see the bulge, the thing actually coming out, as Dr. Lim was mentioning. Those, by then, you do have to send them out off to see the urogynecologist or to see the gynecologist to actually review the structural issues with that. But if not, those that are milder, they actually appear only at the end of the day. Pelvic floor strengthening can actually help their symptoms quite a bit. So please do remember that actually if you see it, they're a little bit symptomatic, you actually start them. They may not actually get to the stage where things are falling out and with friction all the way through. So that's pelvic organ support. So for men, we're talking more about prostate. This supportive function, usually we have issues in the other direction. It's not about laxity, but sometimes you get those men that come in like, oh doc, my prostate feels like terrible after I did like a whole weekend worth of cycling. So with cycling, they're sitting on their prostate, number one. Number two, with cycling, it's a really narrow seat and you're like shifting a lot. So that pelvic floor has to do a lot of work. So if I show you, the pelvic floor has to do a lot of work to maintain that pelvis. So it's squeezing. And if you're on that seat for like 3, 4, 5 hours and you don't stretch after, this can cause a lot of tension because the prostate is literally sitting on that muscle. If you're squeezing and it's really short, you have a lot of compression. So a lot of men, especially those avid cyclists, they find that, oh yeah, I get really bad frequency, I get really bad pain, it gets a bit better, they have antibiotics, muscle relaxants, it does get better. But because the pelvic floor muscles have a part to play with that, from pressure as well as compression of the urethra as well as the prostate. So different sort of issues you have on both sides. For females, because of anatomy, it works more for support. For men, it goes direction of where, oh, the support is too much, and then you end up with compression. So slightly different issues that you'll see in the pelvic floor for men and for women. So this is where we're talking about, okay, incontinence. Why is the pelvic floor important? If you look on the left, you can actually see that our urethral sphincter is supported by these muscles. So again, active component where if this is not working, you can get worse structural sag. If you have things like overactive bladder, even if you have that compressing on the top, you've got a really nice sort of sphincteric action there, it can actually maintain continence because continence is multifactorial. It's the same thing for the bladder neck as well as sort of the rectal side of things, where you have issues. If you don't have issues in the structure, you squeeze, you will get good continence. If you have structural issues, your pelvic floor, if it's strong enough, you get enough coordination, you can actually make up for a little bit of that. So just quick one, because he's already mentioned it, the types of incontinence that we're talking about would be your overflow incontinence with issues with getting things out entirely. It may fill up too much, then it's just an overflow. Then you have the ones where exercise really does help a lot. And there's lots of evidence for that, which is your stress incontinence, because this is making up for the structural capacity and functional for obvious reasons. If I can't walk to the toilet, I'm just going to hold my bladder all day. So things like that. Urgency, as Dr. Lin mentioned, there is some evidence to help, but usually we find that pelvic floor training usually helps more for those that have that positional detrusor hyperactivity. A lot of the things that physios do for urge incontinence, as he mentioned, is actually to do a combination of bladder training together with pelvic floor. But pelvic floor is actually to help reinforce that retraining of the bladder, as well as for those that are leaking, to help them give them confidence to train that bladder capacity back, as well as detrain all the different stimulations and triggers that they have. So just a little bit of an overview there. For bowel function, so if you look at this muscle and the picture on the left, if you're resting, you shouldn't actually have too much of a kink. If you have a squeezed muscle that's really tight, what happens is that actually you really can't get poo out. And also you'll find that lesser urge. So some people, they are so used to going like, oh, I'll go later. You know, those that hate public toilets, what happens is that they just end up with a non-relaxing pelvic floor. They never feel urge until you look at that capacity and they have like a huge urge. They can't control the urge. They leak a little bit. They go to the toilet and they can't flush the poo down the toilet bowl. So these people won't tell you that they're constipated, but they do have a lot of this type of habits that can cause that muscle just not to relax, because habitually it's always been told to, no, I can't go. So it is a little bit of a multifactorial process where you need to figure out, hey, is this person actually holding too much or weak? Because they can present actually in similar manners. So a quick sort of tip that you want to give patients that are having issues with pooping, anytime, they will always tell you, no, I'm not constipated. But then if you look at them and you check the anus, oh, you've got pile tags, you've got hemorrhoids. So those are all the signs of someone straining on the toilet bowl. It could be they're, actually constipated. They could have tightness in the muscles. So the simple thing that we usually say is, if you look at that little picture on the side, to sit with a stool under the knees. And you really want to get your knee angle really high, because that unkinks the pelvic floor, helps you to fully empty. So if you fully empty, you will actually do much better than if you're emptying halfway and then you might have seepage and leakage after. And of course, for those that do have some issues structurally, you do want to get them to strengthen, and that will really, really help their bowel function. But I do have to say, with bowel function, talking about their stools is very important, because then if you ask them to squeeze, 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 you can make their constipation worse. And then after that, their leakage subsequently is actually worse. So we're going to just run a little bit more about stress urinary incontinence, because this ties into sort of lifelong management. Remember, this talk is actually about helping people who are not incontinent to stay continent. So if we look at stress urinary incontinence, I really like this picture because you can actually look, there are things that predispose. We can't necessarily change them, but it's good to know. So things like sex. Females are just more prone to urinary incontinence just because of our anatomy. Race, neurologic, so if you had a stroke, things don't work so well. Muscular injuries, anatomic collagen. Some people with looser collagen are more prone to prolapse, which then causes issues with their urinary incontinence. And family. So promotion, these are things at the primary care we can actually discuss as well. So if you are obese, pressure, that has had links to urinary incontinence. Lung disease because of coughing, smoking, coughing. Menopause. So menopause, we have things like genital urinary syndrome, where the urethral tissues are just they don't recoil as well. So actually managing the menopause, managing sort of the estrogen deficiency with a little bit of estrogen cream, it does actually help urinary incontinence, because you're not helping your pelvic floor, but you are helping those tissues to become a little bit more elastic, just so that that recoil is better. Constipation. If you think about it, if you have a poo that is big enough to block your toilet bowl, it is enough to block your urinary outlet. So people really have to make sure that you're having type 4 poos almost every day, soft, no straining. Recreation. So sometimes if they are drinking a lot, that causes a lot of urinary urgency because of alcohol. That's a promotion for urinary incontinence and OAB. Occupation. So occupation, people who are doing lots of lifting, that's a lot of pressure as well. Certain medications as well as infection can promote stress urinary incontinence. Then we come to things with our subjective history that we know actually insight cause urinary incontinence. Things like childbirth, very straightforward. You've got a really big head, everything coming through, everything is stretched. You can have a lot of issues if that labor goes awry and you end up, the easiest thing to ask is basically, hey, did you have an instrumental delivery? Did you have episiotomy? Did you have to use a vacuum or forceps? Forceps is very, very well known to be linked to stress urinary incontinence after that, just because it's a really big thing going in, and the force you need to pull the kid out in general will cause damage to our poor ladies. Vaginal surgeries, pelvic radiation. So those is because that does affect pretty much the tissue elasticity and injury to the area. So all these things are abnormal things that in your subjective history, if they already got a few of these factors, you'll be thinking, maybe you really should do some preventative exercises to ensure or sort of supplement to ensure that you don't end up going wrong direction. So this is where we can see that decompensation. You might be fine for like 50, 60 years of your life, menopause comes about, and then you have people start having issues, even though they're doing exactly the same thing their whole life. So aging, dementia, debility, disease are all things that don't help. They decompensate the body, can cause stress urinary incontinence. And of course, this is where we all can intervene, which is the behavioral management strategies that Dr. Lin discussed previously, a lot of pharmacologic interventions, devices, things like pessaries can be used, or surgical approaches, which Dr. Shirley, if you want to ask her, can actually discuss a lot more for stress urinary incontinence. So I think this is a very complicated picture, but basically for physios, this is what we kind of manage. We think about the integrity, if the integrity versus the load. So things on the left are things that we can change. Things on the right, not so much, okay? So if you have issues with your closing pressure, which is like we were talking about lack of estrogen, submucosa, resting tone, degree of downward movement, we can't help that, but we can adjust it with different advice or things like pessaries, and exercise can help a few of those things, which is the urethral closing pressure as well as the vasculature. Other things that we can help to reduce the load, to reduce incontinence, is trunk posture, activity, obesity management, exercise, coughing, constipation, and heavy lifting. So you can help Two different things, and then you balance it back out. So now we're going to age. So yeah, what about the people who don't have any issues? Can we prevent? So I did want to mention that a large percentage of our pelvic floor is actually slow twitch muscle fibers and a little bit of fast twitch. So that actually means that just like any other muscle of the body, they need to be worked out, and they are really endurance muscles, stabilization muscles. And why is this important to highlight if someone is getting older? So sarcopenia doesn't matter what gender you are going to have to go through this. With age, we do get an associated progressive and generalized loss of skeletal muscle mass, and the definition pretty much is loss of muscle strength and or reduced physical performance. So there are the statistics currently, if you look overall, it's about 13% for men, about 14% for women. So a few more women get sarcopenia a little bit earlier. This is kind of mostly because of menopause. 60 years and above, you can see that 32% or 33 men, and then 31 women. So I'm not so sure why there's an adjustment with that, but we do know that both genders do get sarcopenia. Okay, it is of course associated with increased ages, frailty, type 2 diabetes. So if you have reduced muscle loss, you don't have your hormones to keep everything nice and juicy on the bottom, you will be predisposed to having urinary incontinence. So what do we do for prevention? So for prevention, actually regular resistance-based exercise as well as adequate protein intake is kind of where you want to go. And if you can see, I think everybody here is probably over the stage where sarcopenia is not affecting us already. You can see that in the graph it's about 25 and about 30, 40, it's a little bit of a downward climb, which means that what we need to do to maintain our muscle mass as we age gets more and more important. So at the primary care level, the things that you can do if you want to diagnose, of course, is you can send them for a bit of the X-ray absorptiometry, and then you can actually check this criterion is easily found online. And this particular table is actually from, if I recall correctly, is our Singapore GP Association. So they actually have the criterion there. If you look it up, just type in sarcopenia, it will appear. So the numbers are all there. Things that we can't really test in clinic, hand grip strength, unless you really get that. But if you're curious, you can always get one. Then after that, these are the measurements that you're looking at. But the easiest and most accessible diagnostic tool that I would really recommend is actually the 5-time chair stand. All you need is your normal chair, back it into the wall just in case for safety. And then all you need to do is get them to do hands across their chest, sit to stand 5 times. If you find that they have more than 12 seconds, then you will already know that, oh, their muscle performance is really not the best. This is something to indicate that strengthening it should be a priority. Of course, you have those with sort of osteoarthritis and things like that. Pain can be a consideration. So then you would have to take that into that diagnostic as well. Other things that we would do from a physio perspective is also the 6-meter walk test and the SPPB. So these are a little technical. They do take more time, as well as they do take a little bit more equipment, but they're easily accessible tests if you want to do them in the clinic. So if you look at this one, if you want to take a screenshot, it's quite easy. You just need a standard chair height, a timer, and then after that, you literally just take the time when the buttocks hit the chair. But do make sure they're not going like bam, because that's really not good for the ischial tuberosities. And also sometimes they will fall backwards. So you do want them to be controlled. You would actually test them about 3 rounds and the average would be taken. And then remember, it has to be below 12 seconds. Gait speed, actually, a lot of times you can do gait speed in the clinic as well. There are a few different ways to do gait speed, which is you can actually just do the 3-meter walk test and then you just calculate meters over seconds. And then after that, you can actually do a longer one if you want to do cardiovascular as well, which is the 3-meter, 4-meter, 6-meter, and 6-minute walk test. So there are different versions of the walk test, but I think the most accessible if you're in clinic would be the 3 meters and just calculate accordingly. You have with the SPBB, it does take 10 minutes. It is literally your sit to stand, your gait speed, and a few balance tests. So that one needs a little bit of practice to get through it within 10 to 15 minutes, but it is very accessible if you are keen to do them. So, recap. Strengthening the body prevents muscle wasting. And we know that that's really important and we have to keep it up. Anybody past 35, let's do strengthening. Muscle wasting prevents incontinence. And then now I also know that, okay, general muscle performance, not that hard for me to test it out. I can test it out within 10 minutes. But what do I do with those results now? How do I tally my results to actually giving advice to somebody with strengthening and to prevent incontinence? So if you have opened our health promotion board, they actually have very good pictures. You will see that this is our Singapore Physical Activity Guidelines, and they're actually very, very well planned out. So if you look on the one on the left, you will see that this is applicable for anybody 18 to 64 years old and 64 years old and above. So let's say you've got somebody 40, 50s, already kind of retired, wants to focus on their health. You would say, okay, everybody, let's get moving. So you do want to do 100 to 300 minutes. And this is talking about cardiovascular. You're talking about strengthening. We're looking at both, both ages. You do have to do 150 to 300 minutes. Both ages need strengthening. And we're talking about moderate or vigorous intensity of muscle, like lifting heavy things. And heavy things is all relative. To some people, 10 kg is heavy. To other people, 50 kg is heavy. So you always want to work within a range where you can continue strengthening yourself, which is that minimally 40 to 60% of your maximum lift. So for those that are above 50, you will actually know that you do have to add a little bit more emphasis on balance. And you add that to about 3 times a day, 3 times per week at a moderate or greater intensity. So if you look at them, relatively similar, but for those that are 50 and above, you want to add that balance in balance activities and moderate a little bit more. So let's say, how do I prescribe exercise? SMART goals. We always want to remember, be specific, be measurable. Is it achievable, relevant, and is it time-bound? So that's the first one, because this is where you put your goals. When you say, doctor, I actually want to, then you put SMART goals there. And how do I get to my SMART goals? You just remember a simple one, FIT, F-I-T-T. You're thinking about the frequency, your intensity, the type of exercise, like strengthening, cardiovascular exercise, balance, and the time you need to do it. So, little example, I want to exercise enough to maintain my muscle mass and continence in the next 30 years. So this is a 65-year-old male. So then you'll be saying, okay, you never exercised in your life. Maybe we should start 40% of your RPE. So you want to be at rate of perceived exertion, about 40%. 40% is actually very easy. You actually can be talking and laughing. 60% you will be, oh, I'm a little bit a little tired, but still able to continue and talk. Cardio, 2 times per week. Strengthening and balance 2 times a week. So that's you got like 4 times a week, and you just want all of that to total 150 minutes per week total. So if you're looking at that, that's really not too bad, because I know I need to do my cardio, maybe a brisk walk twice a week. Maybe I'll do that for about 45 minutes, and then strengthening and balance exercises, that's only 2 times a week. And you've also got another like maybe 1 hour, that's already 150 minutes per week. And it's very, very measurable. You should not be too tired, 40% and everything. If you want to progress, you get a little bit better, you've gotten used to it, then yes, you can go to 50 and 60%. So I would say normally, if you are seeing patients that are a little older, you don't want them to go to like 70, 80% right from the start. It can be, number 1, very strenuous. Number 2, they take very long to recover. Number 3, it's much easier to injure themselves, especially if this is unsupervised exercise. So just examples of CV exercise, we're talking about walking, cycling, stairs, swimming, HIIT, but low impact. So if you look online, there are actually a lot of YouTube, very, very friendly exercises so you would just put older adults. And actually you can find these HIIT for older adults. And they're quite fun. They're usually small bites, 10 to 15 minutes, which are perfect for like just getting started. General body weight exercises, I would say, that are better for continence specifically are things that are upright. Because upright, you have your stability muscles, anything that requires lower limb. So you're talking about your squats, your side squats, your split squats, your deadlifts, your tiptoes. All of these exercises, you do want to work them at that rate of perceived exertion, 40 to 60%, which means that you can talk, I can do my lifts, it's not too bad. I cannot go on forever, but I should feel a little bit of pressure. So that is that sort of percentage that'd be really, really nice to be kind of advising on. So that's for those that are not actually incontinent. What about those that are incontinent already? So this is where the specific pelvic floor retraining, reviewing their behavioral factors will need to be looked at to see whether it's a retention issue or a getting out issue. And then after that, you can actually do specific sort of strength prescriptions for that. So it can actually be the sort of primary care level without too much issue. Just need a little bit of practice, because if it is too difficult, for example, if I say, all right, everybody contract your pelvic floor now, and you hold. Some people at 2 seconds will be already given up. While some of you are like, hey, Rachel, that's really easy. I'm still holding it pretty easily. If you gave someone that was really weak a 10-second contraction, they would have to squeeze everything from the top to the bottom, which would not be helpful. That would actually cause some people to leak. And also, number one, the muscle has already given up. So you wouldn't get the strength improvements that you want. So let's just run through some certain nice sort of structures that you can actually use the next day to actually check their muscle strength and their capacity. So number one, you want to think about isolation, identification, and improvement. So I like to say it's the 4 I's. You want to correct muscle identification. So for females, usually it's quite nice if you have a little picture up, or if you guys just pull up the Googles to show them, hey, these are your muscles, this is where they're at. And then after that, explain to them, this is why you need to do this. A lot of times you need to be able to isolate first before you can actually do a strengthening program. Secondly, you want to make sure that they contract correctly. So it is normal to have a little bit of abdominal engagement and butt squeezing, but you don't want that to be most of the movement, which is why the identification is important. So improvement is similar to what we talked about: frequency, intensity, type, and type. So if you find that after 8 contractions, they have given up, the muscle's not working anymore, you know this is their max. So you work them at 40 to 60, which then ends up with a 3 to 5 contraction, 3 to 4 sets daily. That's how you would kind of use this FIIT sort of principle, as well as the rate of perceived exertion, to give them an appropriate dosage. Just like medicine, right? Sometimes you need to tail it up, sometimes you need to tail it down, work with the person. And lastly, this one is usually where it can be quite tricky if you're not with them and you don't actually know how to do biomechanical assessment. It's the functional integration. So meaning that if they are leaking when they are coughing, or leaking just when they see the toilet sign, you'll need to get them to practice actually when they're in that situation to pre-contract, and then after that go on. So let's practice a little bit of isolation. So first of all, if the patient is really not understanding, they're okay with it, you can actually do one finger on, meaning that you are around the perineum or in. So for men, you're talking about anus, in. But that one usually gets a contraction of the anus. So if you're talking about urinary, then you'll be thinking around the vagina, around the clitoris. So to show them, this is where I want you to move. And then you get them to squeeze, relax. A few different cues I'll share in the next picture slide that you can use, because different people understand things differently. So you might find one verbal cue works for one person, one verbal cue works for another. Another one that you can practice now, literally while you're sitting down, is to just lift your hips up, sit on your fingers right there, and then you just want to be in a C shape. And then I want you to contract your anus and relax your anus. So the anus cue actually is the one that's been shown to work the most for the most people. Some people don't really get that anus cue very well. So things that you can say is, can you hold in your fart? Can you hold in your pee? And then relax. So you should feel a little bit of a lift. It's not going to fly away from your fingers, but you can feel less pressure on your fingers. Another accessible point is on the coccyx, so literally at the tailbone. You don't have to push on it, but right next to it. If you're working it well, it will flex in and it will relax back out. And just now, as Dr. Lin was mentioning, the urine stop test is actually quite good. And in fact, for patients that already have issues stopping their urination flow, you would say it is perfectly fine for you to actually practice this on the toilet. But you do want to tell them that you only want to kind of practice once a day so the muscles get used to it. And you also don't want to be practicing multiple times during the flow. So normally you will practice it mid-flow. So meaning that, maybe you pee for about 5 to 8 seconds, about 1, 2, 3, you stop, and then you relax and you allow it to start. The problem with stopping it too early is that then some people find that that start-stop becomes a habit. The second part, if you stop it at the end of the flow, is that sometimes there's not enough volume within the bladder to restart the flow, and then people get retention and they're going to the toilet more often. So there is actually new evidence around this area, but it's not clear whether it does cause retention. So we normally try to be careful. We just say mid-flow once a day. For the finger on or in the vagina, that's usually for women, and generally that's for urinary. So we're thinking of that lift, and that lift also helps more for prolapse cases. Lastly, if patients don't get it at all, you can actually use singing cues. So things that you can try now, you're off, everybody's got their sound off. You can go, ee, you do an ee, you can actually feel that all the muscles on the bottom will have to squeeze. Or you go like, you want to let go, you want to go, you will feel that together with your diaphragm, the muscles on the bottom will actually relax. It's a bit easy to feel with men because you got that scrotum will actually relax onto the chair. So these are nice ways for you to identify and isolate the muscles to make sure that when you do the exercise, it's mainly the pelvic floor working. So this one, nice cues. You've got men and women cues. So elevate the bladder, nuts to guts, testicles away from cold water. If you want to do more urinary cues, it will be turtle into its shell for more penile shortening to stop the urine. If it's just general, you're talking about holding gas, anus upwards. So for the gas cue, you will find that people that can get the front and the back and the middle working, they don't have any structural deficits. If they have structural deficits, meaning they've gone for surgery, they've had radiation, they already have leaking, the cue may not work because that indicates there's some structural damage. They need to actually use different cues to actually strengthen the front and the back. So for women, back passage, stop yourself from passing wind, urinary, also thinking about that vulvar skin around that front passage. Other ones that work quite well, especially for the bubble for women, is thinking if they've had sexual intercourse, you can ask them to think about or practice while they're with a partner and the penis is in situ. Then you're thinking about that contraction. So they have different isolations. So the bulbal will be more contraction, and then with that bladder, it's a little bit more that clitoral movements. Having the cues are quite different. So depending on what you want, you can do front, middle, and back. Tactile cues I've shared before, and then you can do this all in the picture, yeah? So lastly, we're talking about improvement. So how do we improve? Yes, I know how to contract now. You want to make sure that they can actually hold. So you're going to try now. You're going to squeeze and hold about 50%. Don't do 100. And you're going to be able to talk. You're going to be able to laugh. You're going to be able to continue that holding. So that's usually for urination. If we're talking about the anal sphincter and this person has fecal incontinence, we do find that you do need longer, 30 seconds, 1 minute of hold time. Then it's basically because the poo is a lot heavier than the pee usually. So you find that they need more endurance to kind of manage, more strength to be continent for poo. So usually you do want to say relax the muscles after, if not you might end up with retentive issues. The one that usually works for postpartum, especially if it's just cough and sneeze, I don't need to see physio. Can you just give me one exercise to fix it? So the neck is literally, you're just going to go squeeze, squeeze, squeeze. And usually you want to practice squeeze, cough, Squeeze, cough, squeeze, cough. And the whole point of this is actually, it's not that they're weak because they're not leaking all day, but it's the timing. It's not fast enough and not giving enough pressure and cold pressure to reduce, to avoid that sort of leakage. So it's just getting that muscle to work a little faster. And then you'll find that, oh, actually, I don't leak already after 2 to 3 weeks of just practicing this about, 3 or 4 times a day. It actually is a very, very awesome exercise because that's all you need to do. If they have no structural damage, just have to work them a little faster. Most of it goes away. Lastly is functional progression. So this usually is if this patient is more active. I'm like, oh, I love to go for my jump class. I can manage like maybe half of it and the rest of it just, goes all over the place. So they do need specific exercises because the muscle needs to actually manage higher load. And to tell you the truth, if this person can jump on a trampoline for a very long period with their bladder full, they are pretty strong. A lot of times it's a lot more about the coordination, and then after that you have to do that timing just like the neck. So they're not weak because they only leak at certain things, but they do need to train themselves to manage that capacity a little more. So kind of in summary, holistic management of incontinence is that you always start, if you look here, with lifestyle, behavior changes. So what are the aggravating factors? What are the things that you're not quite doing right and is really loading up your system? Doesn't matter whether it's bladder, doesn't matter whether it's strength, doesn't matter whether it's poo. So you're looking at toileting behavior. Are they avoiding to go? Are they holding their urge? Diet, are they taking enough fiber so that they can poo daily? Hydration, a lot of them actually reduce hydration so they don't have to pee, but that increases the bladder irritation. Sleep is important because that helps with recovery. Physical activity, which we just mentioned, you want to avoid sarcopenia as long as possible. And stress management, especially if you are a little bit on the type A, a little bit oversensitive to certain things, stress management can be more helpful than a few of the other things. For pelvic floor, we have plus minus biofeedback. So this is really a physio sort of term. Biofeedback just means that we are using different things to teach you how to do things. So a mirror is biofeedback, fingers around the anus is biofeedback, using fancy equipment is also biofeedback. So if you're talking about ultrasound, EMG, neuromuscular, these things you would actually have to find a pelvic floor specialist to do. Not all physios actually do cover these things. And lastly, this is usually also physio. We will actually look at breathing, abdominal coordination, retraining, balance, mobility, alignment, and resilience. So overall, we're going to look at the whole person, not just the pelvic floor. And I think with that, I'm pretty much done. So the summary is we all have pelvic floors, male, female, doesn't matter. Each same, but different, just different issues. Staying active really helps. So we're remembering we're looking at 150 minutes to 300 minutes per week. Start small, build up, stay consistent. And you want to have those big pillars, which is you have your cardiovascular health. You want to have your lower limb exercises and strengthening. If you are well, just do enough general stuff. That's enough. Manage your weight, manage your strength. And then you've got for older adults, you want balance because the last thing you want is to fall. And then, after you fall, mortality is 3 years, especially if you have a hip fracture. Lastly, if there are signs of dysfunction, that usually means that something already structurally is not coping very well. They have decompensated. For them to manage the normal activities, they actually have to build up on that impairment first, make sure that that's strong before they move on to the general. That being said, general is still useful for everything else, but it just may not help so fast your incontinence issues. It still will help, but maybe 10-20% versus if you did like strengthening, like specific strengthening first, then you go like 80-90%, you do your general, the last bit, the general strengthening will actually take care of. And with that, I'm done. Now remember, questions were supposed to be done at the end, yeah?
Thank you, Rachel, for the insightful sharing.
No worries.
Okay, next we have Dr. Sharmini. Let me, pin her. Okay, Dr. Sharmini is a senior consultant with a SKH Sengkang General Hospital. She has an interest in clinical education where she organized regular clinical bedside sessions, interactive discussion, as well as participated in the running of various surgical courses and conferences for both undergraduate and postgraduate students. She was also involved in managing the objective structured clinical examination for the final year medical examination. Her topic today would be on feeling bloated and blocked. Over to you, Dr. Sharmini.
Hi, everyone. Hi. Hope everyone can hear me. Just let me share my screen so that we can start our session. As you know, we deal with constipation. I'm sure most of you would have dealt with constipation all the time. So pretty much my title of my talk will be Feeling Bloated or Blocked, Tips and Tricks in Managing Chronic Constipation. So my aims of my talk, we will be dealing with the definition first and then the initial management of constipation. And then we need to actually know the difference between slow transit and obstructive defecation, and also be aware what kind of investigation and treatment options are available for those with persistent constipation, right? So without further ado, let's go to the first part of it. So I like to go through a case because I think then it becomes better to relate. And I'm sure in this case, you surely would have dealt this many times in the past. So Mrs. A is a 55-year-old lady, presented with 2 weeks history of constipation. She usually has normal bowel habit, but now she only goes every 3 days, and obviously she is very worried about it, and it's hard in caliper, and she's got incomplete evacuation of stools. But otherwise, she's got no other red flag signs, and she's got no family history of colon cancer. So very classic history. So prevalence of constipation is actually quite prevalent. It actually can reach to about 14% if you pull all the data across the whole region. And it's usually most prevalent among the non-Caucasian, among women, and those who are institutionalized. Okay, so definitely, and also even among the patients with neurological issues like Parkinson's and things like that. So they are more likelihood in developing constipation. Now, definitions, there are two groups of that definition. One is by the American Gastroenterology Association, and the other one is what we are actually very familiar with, which is the Rome 4 criteria. So, as you can see from the American side, they have what they call the normal transit constipation, and then the isolated means slow transit, there's nothing else. Then they have the obstructive defecation, which could be associated with either normal transit or slow transit. But if you look at the Rome 4 criteria, they have the functional constipation, which stands alone. Then they have the constipation, but with an element of IBS, irritable bowel syndrome. Then they have the defecatory disorders. So that is how they have put the different kinds of constipation together. Now, if you look, so I'm just going to concentrate on the Rome 4 criteria because this is actually what we usually use in Singapore. So you can see that the symptoms has to be more than 6 months, and they should have symptoms like straining, hard stools, can't complete the evacuation, they feel that something is blocked, and they have to sometimes do a different kind of maneuvers to help them to defecate. And then usually it must be less than 3 spontaneous bowel motions per week. Okay, but I just want you to look at the difference between the functional and the IBS constipation. So with this functional constipation, they do not have loose stools in their history at all. Okay, so but when there is an IBS component to it, there is some loose stools in their history. So they usually will have some loose stools, but most of the time, they will have constipation. So 75% of the time will be constipated, but 25% time will be loose stools, and they will have some pain. All right, so IBS is a little bit different when they have got pain and a bit of loose stools, but functional constipation is just the bowel movement being slow. All right, so if you look at all the studies that you look at or any journal articles, they also have the same concept. Okay, so always remember the difference between functional constipation and IBS constipation. And usually, as you can see, it is less than 3 bowel movements per week. Okay, that's pretty much how they define them. All right, so now to help with communication among medical health professionals, it is very important that you know this chart because it's very hard to kind of explain what kind of stools they have, especially when we're talking from one doctor to another. So, usually you show this chart to your patient and you say, okay, what do you think your stools will look like? Your ideal stools should sit about Bristol type 3 to 4, I would say, or even 5 is also okay. But 1, 2 is pretty much considered quite constipated. Okay, because and then 6, 7 is when you notice a little bit on the diarrhea side. Okay, so please be very aware about this Bristol type chart, so that we don't get miscommunication and things like that. And also, you can quantify the symptoms better. Okay, so now we're going back to the same case. So this is the same case that we just went through earlier. So now it is very important that you rule out primary and secondary constipation, all right? So the first thing when you deal with a patient, you must look at their medication, like it's any new medication that they've started. So there are all sorts, like it could be analgesia, antidepressants, opiates, whether they have just recently diagnosed Parkinson's, antipsychotics, whether they got epilepsy and things like that. So all these can cause constipation. Of course, like iron tablets, anticholinergics, like, especially those people with urinary incontinence, when they start on some anticholinergics, unfortunately, the side effect is constipation as well. Okay. So then of course, colonic obstruction. So the number one thing you're concerned about is whether this patient has got a colonic malignancy or anything like that, or any strictures and things like that. So metabolic, like diabetes, thyroidism, hypocalcium. So you've got to make sure you check all the blood tests. I mean, basic blood tests, like, check their thyroid, check their calcium. So this is what I always do in my clinic, because it's very, and there are occasions where I pick up these other causes that's actually explain their symptoms. So, and then myopathies, these are all quite rare. And then neuropathies like Parkinson's disease, spinal cord injuries, recent stroke, or multiple sclerosis, and of course, could be immobility and cognitive impairment. So there's a whole range of causes, and you just have to kind of go through it carefully. So once you have gone through this, and of course, if you're worried about colonic malignancy, all of them should have some kind of colonic evaluation. So in this case, the patient is quite fit and quite well, so you make sure that they definitely have some kind of colonic evaluation, and the best colonic evaluation would be a colonoscopy. So you're referred to the specialist, and then they will do the needful. So it's usually a 15-30 minute process. I mean, it takes about that time to finish. It's done under sedation, and then if they find any polyps or any cancer cells, we will take biopsies. It's done under day surgery, so it can be claimable by insurance or use their MediSave. And usually they will get a report on the same day. But if there's any biopsies taken, it takes about 2 weeks for it to come back. So that's usually the usual process of a colonoscopy, and that's to make sure that we exclude any organic causes. All right. So anyway, so just say you've done all your due diligence, and you make sure that there's no other causes and everything is all clear. You're dealing with either a IBS constipation or a functional constipation. Then you have to start on initial management on this case. And pretty much you got to look at their diet. All right. You got to make sure that their fiber and water intake is balanced. Okay. So if they take, so there are some patients who are, they're well educated. They read through Google and they say, oh yeah, I eat my fruits and vegetables, and they eat tons of it. Okay. They eat tons and tons and tons of it. And what happens is, if they take too much fiber, but their water intake is not adequate enough, then they can get constipated. So that's one thing you got to be very, very careful about. Okay. So water is very, very important. Fiber is also very important, but their water has to be adequate to actually balance with the fiber intake that they have. So sometimes when they are really diligent with the fiber intake, quite contradictory, I would tell them to cut down their fiber, because they have to take like 2-3 liters of water because of the amount of fiber they've taken. So once they do that, then suddenly their bowels come back to normal. So you got to be quite connection between the fiber and the water intake. Now, things like alcohol, tea, and coffee, they are very dehydrating. All right. So yes, they make them pee a lot, which is true because they have that effect. But what tends to happen is they lose water. So when you lose water, then you become then of course you become dehydrated. Then the likelihood of you getting constipation is high. So these are the few things that you could do in your primary setting. And then, of course, you got to tell them that you can't have a sedentary lifestyle. You got to keep moving, okay? So movement makes bowel move, okay? So they just got to do that. And the main thing about this, you got to manage their expectations. You'll be surprised that a lot of my patients, they like to feel that they must open their bowels daily, even though they have no urge. All right, so they will sit in the toilet and they will, no matter what, they will strain, they will push, and they will produce some stool, and then they feel happy. Okay, and that is actually bad habit, and that is something that you have to address. Okay, you got to tell them, your body knows where to go. They will have an urge, and then you respect the urge, and then you go. Okay, it could be once every second day or so, but you do not necessarily need to make sure that your bowel must open at a particular day and time. Of course, there are some people who can, but not everybody has to have that expectation. So I think that is where you all can come in to really counsel the patient. You'll be amazed how many myths that they have listened to and what is it that they are thinking about, and that actually they have no constipation. It is what they think that they have constipation. So another thing is good defecating habits. So I would avoid so it's very good that they sit in the toilet, and at most ask them to get a stool. You can get a nice cheap plastic stool from IKEA, and then they lift their legs. And what tends to happen is it actually straightens their rectum. So once it straightens the rectum, they can actually pass motion quite well. So that's why in the olden days, our great-grandparents or grandparents, they will actually squat when they go to the toilet. When last time we do not have a toilet basin. So that's why, it's actually the natural way of how your rectum tends to fall, okay? But now that we are now in a modern society, so what tends to happen then is you just take a stool, and that gives you the same effect, that it actually straightens the rectum. So these are little tricks that you can kind of advise your patient. Okay, then of course you have the wonderful laxatives. Okay, there are all kinds of laxatives out there, and it's very important that you know what they do. Okay, not one laxative is the same as another laxative. It's very important that you know their mode of mechanism, because when you actually prescribe these laxatives, it's very important that you take one from different class. Okay, so that means you take maybe one stimulant. Usually people will take one stimulant and one bulk forming laxative, or one stimulant or one osmotic mode mechanism, okay? Because it doesn't make sense if you just take two stimulants, like, a bisocordial and a senna. That does not work well, okay? You need to take one of each class, and usually you got to tell them you got to be quite compliant with it for 6 months, okay? And then see whether they are compliant to it, and whether they got any difference. Now you can change in between that 6 months. So in the sense that after 2 months, no difference, then you can change to a different kind of class. That is absolutely fine. But the main thing is you got to make sure there's some kind of compliance over the 6 months period. Okay. And what tends to happen is compliance is always an issue, because patients always think they will take one tablet or one, a drink, and they expect immediate effect, but that doesn't work like that. Okay, so it usually takes a few days to kick in before you actually have some kind of regularity of the bowel motion. So now there are 4 types that I know of. So there's a bulk forming one that basically retains water, so means basically it's like a fiber. So it makes your stools quite big and bulky. So that is fibrogel. Okay. I wouldn't recommend this for someone who has got severe diverticulosis. Okay. Why is that? Because usually their colon is very narrow because of mural thickening and hypertrophy. They would have been straining for all their life, or severe, and so they have lost the capacity for the colon to expand. Okay. So normal colon can expand and come down, no problem. But when it becomes very fixed and fibrous, it doesn't have any give. So when you give things like fibrogel for this kind of patient, they get a lot of pain. Okay, so that's why they'll be like, oh, doctor, when I take this, I just feel pain, and then that's pretty much not the right kind of laxative. So you just got to be very aware of that. Stimulant is a very good drug as well. It works very, very well. So what it does is exactly what it is. It induces peristalsis. So you get the urge and then you need to go. And that's why some patients can't take that pain, because sometimes they'll feel that, oh, when I take this tablet, wow, I feel like my whole colon is trying to empty itself. So you got to be, you can cut down the dose, or you take every second day or something like that. So some of them can't tolerate the force of the peristalsis, you know, when that, but it works really well. Then, of course, the most common one is the osmotic effect, where they increase fluid in the colon, produces a bit of distension, and it stimulates the peristalsis. So that lactulose, Forlax. But what it does is it causes a bit of bloatedness. So you have patients saying that, oh, when I take this laxative, I feel very bloated, feel very gassy. But that's because it's a very common complaint with this class of drugs, right? Then you have the service sweating also. It reduces service tension, and that's glucosamine. So that's absolutely fine. So you can just try this and see what happens. All right, then of course 6 months has passed. Then what will happen is Mr. A has been very diligent. You know that she's been very compliant, and she tells me that, you know, every morning and night I take it, doctor, you know, but you know what? Nothing is happening, and you already done a colonoscopy, okay? So you know already the primary causes of constipation you have excluded. The scope has been clear. You're dealing with purely a functional constipation here. You have tried the laxatives, and now, you know, the patient is just getting so frustrated with you now, and he's saying that, you know, my quality of life is bad. Now I'm sitting in the toilet for 30 minutes. I can't even go to work on time. So you can tell that this patient is just getting, you know, I mean, getting really, really upset. So this when you can actually refer to a specialist center, because these are things that we do, okay? So to kind of help this patient, then it's when you do. So what do we do in the specialist center? So in the specialist center, we usually try to discern what kind of constipation is there, okay? So there is the slow transit constipation, and then there's the obstructive defecation, okay, in the other side. So they have very, how to say, distinct symptoms from one to the other, and that gives me an indication as to what is it that I'm dealing with, okay? So, you know, usually for the slow transit, they have no urge at all. Okay, they can actually completely evacuate if they actually do go to the toilet. They do not need to do some special, you know, they don't need to digitate themselves or try to put a finger in to help them defecate. And usually they can have bloatedness and abdominal pain, but bloatedness and abdominal pain is a very, very vague kind of symptoms, right? Because they're so bloated that they have pain. So these are the ones that will go to toilet like easily once every week or once every 10 days, okay? And they are worried as to why they are not defecating. The obstructive defecation is very different. They have the urge, they have the sense to go. They know that there's something there, and they will go to the toilet and sit down. But no matter what, nothing comes out, or maybe a little bit comes out, or they feel that there's more to come out. And then what will they do is they'll sit there and strain because they know that there's something there. And sometimes they have this, you know, they will try to sit in one way, or they pour some water here, or they try to manipulate the perineum, sometimes transvaginally or transrectally, depending how it is, to allow the motion to pass through. So very distinct kind of symptoms. So depending on what kind of symptoms is how I guide my investigations. So for slow transit, usually I would do a transit study. Now, there are other types of studies like colonic manometry and radionuclide gamma scintigraphy, but they are very, very specialized tests, and I do not think they are available in Singapore, okay? But they are available in very, very specialized centers in the world. So, but in Singapore, we usually do some called a transit study. Then on obstructive defecation, usually we do what we call an anorectal manometry to look at the anal pressures and abdominal pressures while they're defecating. Or sometimes we do an MRI difficultography or a defecating protogram. Okay, so it's a dye that goes into the rectum, and then they initiate straining, like so they're going to defecate, and then you can see how the rectum moves. In the MRI, it's pretty good because you can actually see how the uterus moves and how the bladder moves. And you know that sometimes in these patients with prolapse and things like that, they are actually tricompartmental. They have problems in each of the organs. Okay, so that's why MRI also is pretty good. Balloon expulsion test is another thing that can be used in some centers. I'm not so sure whether Singapore does this, but there may be one unit or so who does this, but definitely internationally they also do it, but it doesn't matter. Once you have a decent anorectal manometry, usually you have enough information to know what is going on. All right, so this is just an example of what this transit study looks like. Okay, so basically they take a little tablet with a lot of foreign little pegs in it, okay? And then after 5 days, you're not supposed to take laxatives during that time because if not, you just falsify the results. And then you take a photo or an x-ray about 5 days later, okay? So if you look at the image on your left, so you can see all these little, you know, foreign body pegs around there. And this is classic of slow transit. Okay, because by right, by 5 days, you should be clear. Okay, it should be clear. You shouldn't be seeing a lot of these pegs. Okay, but then for you to see these little things, it just shows that the colon is just not emptying itself. Okay, so it's classic of slow transit. Then if you look at the one on your right, you see all the pegs are sitting there in the pelvis, and that could be an indication of obstructive defecation. Now, I would not use a transit study to diagnose obstructive defecation, okay? But that's why I put a query there. But it's something to, okay, let's say if you do this study and if it fits the picture, it fits the picture. But it is not a study to use to diagnose obstructive defecation, okay? But it can add evidence to your, you know, if you do have suspicion that you're dealing with obstructive defecation, all right? So now this is what I usually do for obstructive defecation. Okay, so what I do is a defecating protogram. The defecating protogram is not as detailed as an MRI because it only looks at the rectum. So if you see that, you can see a dye there being placed in, and in a normal study, so on the left is a patient is at rest. Okay, means not doing anything. So that's how your rectum looks like, okay? It has a bit of a bend, all right? And then when you pass motion, which is the picture on your right, it straightens, okay? Then you pass motion, all right? This is what you're supposed to do. This is a normal study, and this is what I want to see. Every time when I look at the picture, I need to see that the actual angle actually lengthens, and you don't have this, okay? And that helps you with that. And if you just going to show you the picture here in this diagram, so you can see that at rest, you have the little angle, all right? And that's normal, and that is part of maintaining continence, all right? It's important that it does this, because if your rectum always stays straight, by the time you feel the urge, you're already the motion is already out of you, okay? You know what I mean? So it needs to have a little bit of a bend to give you a bit of continence. Then after that, when you're straining, the puborectalis muscle relaxes, and then then the rectum straightens, all right? So that is normal, all right? Normal. So now, in someone dealing with what we call anismus, means someone who is not relaxing the right muscle groups, okay? And then you've heard from the physiotherapist how they train the pelvic floor. What is it they're trying to do? So of course, in incontinence, you're trying to strengthen it. But in these people with constipation, sometimes they're so stressed and they have high tension, they are contracting the wrong muscle. So instead of relaxing the puborectalis muscle and relaxing the anus, they are tightening it, especially when they are so frustrated and they want to pass motion, they actually contract the entire body plus the pelvic floor. Okay, so we are looking at another extreme here. We're not looking at other incontinence. So incontinence, we all deal with strength, and getting it stronger. But these are people who are very strong muscles, okay? But they're losing it the wrong way. And you'd be amazed, you would think, right, that you know how to pass motion when you're a baby. Why is it that when you come to a certain age, you don't know how to pass motion? But it's just, you know, it's just basically it could be bad habit being acquired through many, many years. And sometimes it could be that, oh, you know, I need to pass motion every day at 7 o'clock in the morning because I do not want to use the office toilet. So you know what? I need to pass motion now. So people have this kind of concept, and during this mind training, then the body also, you know, kinds of adapts to this kind of bad habit, and until to a point that it has come to this state. Okay, so if you look at these 4 pictures, the resting is fine. That is on the upper left corner. Okay, then on the squeezing side, you can see that is correct. Okay, so when you squeeze, you do not want motion to come out. So it's okay to have the angle to be very acute, and that is okay, all right? Now, if you look at the bottom left corner, the patient is straining, all right? And you can see the angle is not opening. It is still in that angle, so that is not good. I want it to lengthen, to straighten, but no, I don't see any difference. So if you look at the squeezing and the straining, there's no difference. So that means the patient is not relaxing the muscle that it's supposed to do, all right? So even though she's trying to defecate, or this patient is trying to defecate, no, nothing is happening. All the barium is still sitting there, okay? So that is what I'm trying to tell you here, that you do not see any barium evacuation here because the angle is still very acute, so it's not going to come out. Okay, so and as well as, you know, during the same time when they're doing this test, I can also look at prolapse and rectal seal as well as interoception. Okay, interoception is like a telescope where the walls coming together like a telescope. So here I can see a rectal seal on the left, and then on the right, not just have a rectal seal, but you can see the bowel interocepting to each other. So there is a bit of an interoception going on. So that also does not help when the bowel does that. It's not easy for the bowel to evacuate. And in these cases, I'm not surprised if the patient has to put the finger in the vagina to press down the rectal seal, the bulge there, to help straighten the rectum, and then it passes out, okay? So just for you to get an idea of how patient trying to adapt when they come across symptoms like this, okay? Now, the top line is the MRI. So look at how the MRI is. The MRI is beautiful. So you can actually look at all the beautiful organs there, and you can see how it is. So this is a manometry. Manometry is what I put a little tube in, okay, into the anus, okay, and it tells me pressures. That's all it does, okay, pressures of the abdomen and the anus, all right? So if you look at the bottom line here, so this is the abdominal part, which is the, if you cut a line across, the one at the top is abdomen, okay? Abdominal pressure. The one below it is anal pressure. So when you're at rest, you're resting. So your anus has got a bit of a pressure, and that's normal, all right? So when you squeeze, if you look at it and you squeeze, that's the letter G, all right? If you squeeze, your anus will contract, correct? So that's when the color becomes red, because you're contracting. So when it becomes red means pressure is high, okay? When it's green means pressure is low, all right? So that's how it's supposed to be. If you look at H, when you are defecating, what tends to happen is your anus must relax, because then only it will open, all right? So it opens, then motion comes out, all right? But if you look at the letter I, this patient is squeezing the anus. It means he's not relaxing at all. So he's pushing, he's straining, he's really trying to go, but nothing is happening. All he's doing is going against a closed anus, all right? So you can see the anal pressure shooting up. So this is pretty much diagnostic of puberectalis paradox, okay? So this is what I tend to see, okay? If you look at J, okay, J means the anus is relaxing, but surprisingly, not enough abdominal pressure. So patient not producing enough pressure of the abdomen, enough to expel the motion out, all right? So this is what we call, means nothing to do with the anus, nothing to do with bad muscle coordination. It's just not enough upward force, okay, from the abdomen down into the anus, all right? So these are things that I tend to do so that I can understand as to why they are going through such symptoms. So this is just to explain to you what puberectalis paradox I'm dealing with. Okay, so in the top picture is normal. You need good abdominal pressure and relaxed anus, then motion passes. And the puberectalis muscle must relax. So the anal muscle relaxes, puberectalis relaxes, okay? Then the anus becomes straight, and then you open your bowel, all right? But when you do not do any of this coordination, you are tightening your muscles, both the anus and the puberectalis, you do not have enough abdominal pressure, that is when you have a problem, all right? So this is, if you understand the concept, and you actually, the patient also should understand this, sometimes it helps them understand their disease process, okay? So now, before we go any further about what we're going to do with this kind of patient, so we've discussed slow transit. Then now we have discussed what obstructive defecation is, okay? But before we go through the management of all these, I want you to know a little bit more about medication out there, okay? So specialized medication. These are medications that it will not be in the primary setting, all right? So you won't get them in a GP setting, all right? But it's something that you may come across when you look at your medication, you'll be like, oh, what are these? These are only prescribed in specialist hospital, And this is usually to help them pass motion. So there's a group of medication called secretagogues, okay? What it does is it increases ions of sodium and chloride into the gut, and then it helps with transit, okay? Usually you will see it in children, okay? I have not seen this in adults yet in Singapore, but it may be something that is prescribed in, in children with chronic constipation that you may come across, okay? So I just thought that I would just discuss this class of drugs. This is called lubiprostone, okay? So they are bicyclic fatty acids, so they come from prostaglandin. So what they do is they activate the chloride channels in the epithelial cells. So these are the epithelial cells in it. So the drug kind of activates the chloride channels, and then lots of chloride and sodium gets into the bowel, into the lumen, and then that helps with bowel motion. So it's pretty good for opiate-induced constipation, and also good for both functional and IBS types. So this I think might be maybe prescribed in KK and things like that. So but mostly on the children's side, all right? Then the other one is called linaclotide, okay? Again, something very specialized for it. Now, this is a very, very specialized and very good for two things, okay? Not just to make you pass motion, because what it does, it actually activates the cyclic guanosine monophosphate, okay, which sits in the epithelial cells, and it's got dual motion. One motion, it means it activates the chloride and bicarbonate channels, so it means more chloride goes into the lumen, so that's one action. But the other action is it also blocks the pain receptors of the bowel. So when someone has got a lot of bowel pain and things like that, cramps, it does a good job. It blocks, it does two things. So very good at using for IBS kind of patients, okay, with constipation, predominant IBS, okay? So these are very good drugs to see. So you may come across this, okay? Then the other one is prokinetics. This is what I use quite commonly for my slow transits. They stimulate the 5-HT4 receptors, and what it does, it induces peristalsis, okay? So that's what it does. It gives a wake-up call to the colon. Do bear in mind, we only use these kind of specialist drugs only if the normal laxatives are not working. That's why I told you 6 months, you try to use different classes, doesn't work, then only we go through this specialized drug, because they are not cheap. Unfortunately, they are not cheap at all. Okay, so these are prochloropride is what you also would have come in. The trade name is called Resolor. So these are selective agonists of the 5-HT4, and we have many papers, multi-center double-blind randomized control trial, and it definitely make a lot of difference between the placebo group and the ones who taken the drug. Definitely very effective. But unfortunately, it's got some side effects. It can cause diarrhea, can cause headaches and nausea. But they're usually tolerable kind of side effects. And you can see that through the years, Europe has used it for many years now. But Canada and US, it took a while to take this. I'll tell you why. But the main thing about this particular drug is that there is no cardiac complication. This is very important, okay? So prochloropride is a very safe drug. Okay, so you don't need to worry. You can just use it, okay? Why do I say that? Because before prochloropride came into the market, actually, there were two earlier drugs that also kind of antagonize the 5-HT4 receptors, but it also blocks a lot of other receptors as well. So it's not very selective, okay? So they call the cisapride and the tegaserod. They were actually in the earlier market before prochloropride came in, okay? So what tends to happen is it causes a lot of cardiac complications. And that's why in the US, they were one of the first to adopt this. They had a lot of problems when they introduced this drug, and hence why it was kind of withdrawn from the market. But now it's been reintroduced, but they're very specified, like, okay, you need to make sure they are younger, they are women, because men are more likely to get cardiac complications, things like that. So, but in Singapore, I don't think we use these drugs. I think we are pretty, we only use prochloropride. Okay, so now, after bearing all this in mind, so I want you to just kind of get some form of management treatment, what we do in a specialist center, so that you kind of understand. So when it comes to slow transit, as I said, we usually use a prokinetic, okay? Because the whole colon is not working, okay? So we use prochloropride. Now, there are some centers that use what we call antegrade colonic enema. That means we will take the appendix and we bring up to the surface. So instead of giving enemas through the anus, you can give enemas through the appendix orifice, and then you give your direction. Usually it's done for children, okay? Because you can imagine that they would not be able to have their anus poked and prodded in the daily basis. So what they do is they intubate themselves, and then they can get medication in so that they can just pass motion as and when. But that has fallen out of favor lately, because you could imagine the valve that we use, the surgical procedure that we use to produce this valve to the surface, gets into a lot of problems. It gets infected, it gets blocked, you can't intubate, and it has given a lot of problems in the many years, but it has been used for a very, very long time. Sacral nerve stimulation is another thing that you may have heard for incontinence. So for incontinence, it's very, very good. For constipation, maybe yes, but it's very plus minus. And because it's a very expensive tool, I don't think it's something that we use for constipation. But definitely for fecal incontinence or even urinary incontinence, it's a very, very good treatment, okay? Then, of course, there's total colectomy. Total colectomy means you just remove the colon, all right? Again, not very common now, all right? So in 20 years ago, everyone's colon just gets chopped off, okay? Very common operation. Oh, you got slow channel constipation, we remove your colon, okay? And what tends to happen, there is a paper who actually seen the function of this patient who went through a total colectomy. Only 30% actually benefited from this surgery. 70% have ongoing symptoms. That's because usually when someone has got slow transit constipation, they also have bowel dyskinesia. That means even the small bowel is not working, or their stomach is not working. So it's not just the colon, it's not an isolated thing. So when you remove their colon, yes, you may have treated their constipation, but they will still have the bloatedness and the nausea and the pain and the distension and all that. So because the IBS symptoms are coming from the rest of the gut. So that's why you have this issue. So now total colectomy is only still done, but not as common as what is done in the past. Then, of course, there are some people who just can't take it anymore. They don't sit in the toilet, then they get a stoma, okay? So I would say these are still going on, okay? Though some of them not so often, but the other two and I do not think that they're actually doing that anymore, okay? So then for obstructive defecation, it's a little bit different, okay? Because as I told you, the muscles are not coordinating itself. Then you give them biofeedback, like what the physios were saying just now, okay? You tell them how to relax their muscles. So instead of telling them to strengthen it for incontinence, you got to tell them how to relax, okay? So you relax the muscle. Sometimes when it's very stubborn, you can put Botox. You got Botox, the pubic rectalis, to enforce relaxation of the muscle so that they can actually relax, okay? Sometimes you can teach them how to irrigate their rectum. So it's like a tube, you go in, they pour in water in, sometimes about 1 liter or 2 to help them evacuate. And in worst scenario, if they can't deal with it, especially when someone is bed-bound or someone who is an invalid, or they just cannot, participate in biofeedback, then you have to do a stoma. And sometimes, and remember I told you there were rectoseals and intussusception, which also bring rise to this kind of problems. Then you can repair this, because when there is a problem like a rectocele or intussusception, it doesn't get better until you actually repair it. But at the same time, if you do not train them with biofeedback, they will just recur again, because the rectocele will just form again. The intussusception will come back again because they have bad habits. So it's very important that even though when you have repaired them, they will continue with pelvic floor rehab, okay? Because this is very important. It does a lot of, there's no point repairing all this, making it all beautiful and nice, but they have the same bad habit because it's just going to come back again and again. So for rectoseals, sometimes urogynecologists repairs them, colorectal surgeons repairs them, because it can be done locally. You can do it through the rectum, you can do it through the vagina if it's very low and localized. You can even do a star procedure, and is a form of surgery that we do. And then, but if there's interception or there's rectal prolapse and things like that, sometimes we do as a trans-abdominal approach. It's done laparoscopically, and that's when we put a mesh in, okay? Because we're also not just are we repairing the rectocele, but we're also straightening the rectum, and that with the help of a mesh, okay? It's like a little sling. So if you look at this picture, We are putting a mesh there on the rectum right down to the pelvic floor and use that to pull it up. Sometimes you do a joint procedure with the gynecologist because sometimes they got concurrent, vaginal prolapse, or so they can do a hysterectomy, or they can put another sling and pull everything up. So basically, same concept. We put a mesh in, pull it up, straighten everything up, and then it's fastened to the sacral promontory so that it stays intact. Okay. So yeah, so that's pretty much it. So I'm just going to there's a lot of my last slides. So basically, when you're dealing with constipation, always exclude organic causes. So colonoscopy, make sure your blood tests are done and all that stuff. Look at their medical history or their medication and then titrate it accordingly. Always, for your part, go for the initial management, lifestyle changes, counseling, look at their habits, managing their expectation, and then you start them on the laxatives for about 6 months, okay? And then once you have done all that, then of course, as you know, we refer to the right specialty, and then so that we can do all these specialized tests and medication that they can have. Okay, and here I end my talk. Thank you very much.
Thank you, Dr. Sharmini. Just do stay on because I'm inviting the rest back, to do the Q&A. Dr. Lim?
Okay, thank you very much, everybody. I want to thank Miss Rachel Tang, our physiotherapist, for giving her wonderful talk on the different forms of exercise about the pelvis. Dr. Harvard Lin, Dr. Shirley Bang, and Dr. Sharmini, our specialist in pelvic floor conditions, for sharing a bit of insight to help our primary care physicians and nurses in the audience to appreciate as well as to manage their patients better. Okay, we are open to questions now. If you have any questions, please feel free to put them in the chat box so that I can share the questions with our speakers. There was one question. Is Shirley back?
No, she is online, but her video is not on, so I'm trying to get her to come online.
Okay, never mind. That can be later because there was a question about self-start antibiotics.
Okay, she's back. She's back.
Yes.
Hi, Shirley.
Hi.
Busy, yeah? Okay. There was a question earlier posed by Dr. Parvati about self-start regime for antibiotics. And the question is, how long should each self-start regime be for recurrent UTI?
On papers, it's 3 days. So we always learn it's either 3, 5, or 7. But practically, I find that 3 days usually not enough. So 5 days. Yeah, at least 5 days.
Thank you very much. Just to clarify a few things, I think Dr. Sharmini earlier mentioned that secretagogue drugs are primarily used in only in the pediatric group. Actually, many of our gastroenterology colleagues who deal with functional constipation do use a lot of these drugs. If you look at all the guidelines today, the newer generation secretagogues after prucalopride and tegaserot are primarily used for IBS predominant constipation or constipation pattern IBS because they find that it helps to relieve the symptoms of the pain better than the traditional laxatives. But I just want to highlight that in Singapore, the older generation tegaserot and prucalopride require a 15-page patient explanation document due to the risk factors associated with cardiac side effects, as you mentioned, from cisapride. And that's why they're not very popular among the specialists. Because if I have to open up the drug, I have to make a patient read through a 15-page document and sign it. So
okay, I didn't know this.
they all don't do it anymore. Because I don't want to do it
either.
either.
This drug though, I mean, you mean it's still in Singapore? It's actually in the formulary?
Yes, but due to the restriction of the way the drugs are prescribed, most of us don't use it. Like anything in life, if it's too tedious, nobody will do it. And and as you brought up, many of the conventional medication are actually very, very useful for the majority of people. Very few patients fall into a narrow band of constipation that require very specialized drugs. And if I were to say one thing about all the talks today to the participants, what you have heard is that our pelvic floor supports all three pelvic organs: the bladder, the vagina, and the anus. And the pelvic floor, no matter what the functional condition is, can be strengthened through exercise. And if I were to ask a question to Rachel, many patients have a problem identifying the floor. So if you are to help our GP colleagues, if they were to teach the patients maybe one or two maneuvers as to how do you teach the patient where the floor is, what do you tell them?
Okay, maybe we start with the easier version. I didn't put it up because I thought it was a bit biased. I don't know whether you can see. I put it. Just give me a second, yeah. Let me take away my background, and then it should be. I do not have to take away my background. Okay, never mind. Yeah, so if anybody's interested, actually you can email me and I will send you a very, very good set of exercise explanation for the men. So basically for the men, it's very simple because you can actually, as long as you don't have any structural damage, right? Actually, majority of men will get it because if you can squeeze your anus, you're not going to fart in anyone's face. You can actually lift your testicles and your penis. So the pictures that I have literally are segmented into the first layer, second layer, third layer. And I would say after I've done this, it's so much easier. I don't actually have to use ultrasound or biofeedback because then you get guys to stand up, sit down. I would say 80% of men can get their pelvic floor contraction quite well. So as long as you can see the penis and the scrotum move, in general, they're quite okay. For females, the problem is the anatomy is the same, but it's so much smaller. So a lot of the times, if they really, really cannot get it right, you will have to use the hands position, so the tactile stimulation or mirror. I will have to say though, our local population do not like to look at their vagina and vulva. So that really, really no, even if got something wrong, they will not look at their vagina and vulva. I think Dr. Lin, you would know more based on your specialization. You have to teach people how to put in, like, don't put your pessaries into your urethra. That sort of situation can happen basically. So having them to literally take the mirror, spread their legs or sit down on the toilet and look at what is happening, I think that's one of the best ways that they can go back and look at what is happening. But you do have to tell them you only see a bit like that door opening and closing. For those that are stronger, the clitoris will move very, very slightly. The most obvious is still anal movement. So the bowel movement retraining generally is easier because you can see that anal lift and squeeze and that pinching. So from a GP clinic, right, if the patient is okay to be ungowned, actually doing the reflex testing is quite good because you just like poke the anus a little bit, they can see that little sphincter reflex is intact. They have a grade 3. So then once they have the grade 3, the patient is like, oh, that's what it's like. Then they can actually sort of identify that's the squeeze and relax, squeeze and relax. So mirror is the first way I would say in a GP clinic is very useful. Secondary is to literally put the hands around, so on the anal sphincter itself. That one is also a very useful cue. But for urinary, is the easiest is actually the urine stop test. It's like the most straightforward is the urine stop test. It's just that we have to take responsibility and really explain to them this is not the exercise. The main problem is, as I mentioned, you don't want to end up with a retentive issue from the habit. But those that are very, very severe, the urine stop test is literally what they have to be practicing the whole day. Yeah, so I think those 3 identification points would be the easiest. But yeah, if you're really interested, just email me and then I'll send you over the guide. So for the men, it's really quite straightforward. The female's much harder just because anatomy is a little bit more hidden. It's much to teach and identify. If they have gone through vaginal births, I would say a lot of them do need specific either electrical stimulation training or the ultrasound to identify, because the motion then is like, it's a flicker. It's already normal. It's so hard to see. So if you want to teach, you really have to actually use the devices. For men, it's a lot simpler.
Thank you, Rachel. A question for Harvard. In a patient with elderly, okay, the commonest group of patients that we see with the female pelvic floor disorder will be the postmenopausal multiparous woman. Yep. And often if they require surgery, we do see quite a number of them having pelvic floor repairs, and these are very, very well done with extremely good results in Singapore, well-published data out of our various hospitals. And therefore, our GP colleagues will see many of these patients either prior to surgery, and they may ask the GPs for advice, or maybe after surgery for the aftercare. Can you share with us, are there any specific pointers that you can give to the GPs when it comes to the aftercare of such patients who have had a pelvic floor repair for pelvic floor weakness?
Okay, so aftercare, I always tell my patients the sutures that we use to repair the pelvic floor, they are almost 2-0 or 3-0, so they're pretty fine. I always worry when they go home. If they suddenly have a big sneeze, or if they have very constipated, they have to force with a lot of force, or if they start to carry heavy things again, these sutures might not hold. So it takes about 6 weeks to 3 months for the fibrosis and the scarring to take place to support the pelvic floor. And it's this 6 weeks to 3 months that if they go to the GP for any symptoms like chronic coughing, constipation, or bowel movement issues, they are treated promptly rather than swept aside. Pelvic floor exercise immediately, probably about 2 to 3 weeks after surgery, if they are able to help, will be very useful. What to look out for? Immediate and long term. So immediately after surgery is any signs of infection. So usually you do have a bit of foul smelling discharge. They may come to you for foul smelling discharge, a bit of bloody discharge. It's normal because the sutures sometimes they attract this bacteria. But if it is excessive, or if you do a vaginal examination and you feel like a collection, then it's not normal, which you should refer back to the surgeon. They may ask you what happens to the sutures. Usually we use sutures that will dissolve on their own, so don't have to worry. For long-term management, to be honest, the one that worries us the most is the anterior wall repair. The posterior wall and the wall, which is we call level 1, usually results are quite good. But anterior wall repair recurrence data is about 20 to 30%. Unless we make the introitus extremely small, watch out for a recurrence, because if the patient says she had a repair before, anterior wall sometimes might still recur. So sometimes all you need to do is to part the labia, and you will be able to see sometimes a mass coming out. Remember when I first said, as long as the mass is not bothering her with her life, she's able to pee, usually we won't be too invasive with treatment.
Thank you very much. Thank you very much. To give a guide to the GPs, I think the current data set is that in a woman in the first 6 weeks after pelvic floor repair, we do not recommend that they carry weights greater than 8 kilograms, because the data is that the reprolapse rate is much higher when it's above 8 kilograms versus below 8 kilograms. So sometimes that's a bit difficult, because if you go to a supermarket, you can find a 5 kilogram bag of rice, but it's very difficult to find an 8 kilogram weight. So they may not understand what 8 kilogram means. So as a simple guide, maybe in your practice, is to tell them, carry a 5 kilogram bag of rice, and that more or less is your limit for the first 6 weeks. If you go a little bit above that for a short period of time, that's okay, but try not to do more because they will want to do housework because they find that the prolapse is gone and they want to get more active, but they need to limit their activity from weight bearing on the floor so that they don't, well, as what Dr. Lin says, they don't damage the repair. Okay, and therefore it's also very important that we manage their constipation, and we actually like to give them stool softeners to ensure that their stool is a little bit on the softer side so that they do not have to exert pressure in order to evacuate stools after the pelvic floor repair. Would that be about right, Harvard?
Yeah, that's the one patient I had. If you don't mind, I had done a sacrospinal fixation with a suture that's actually so it's actually quite thick. 2 weeks later, a patient said she went to the supermarket to buy something. As she was carrying the bag, she felt a snap. Oh, then when I examined her, the whole thing come back again. So that was about quite long ago. So I make it a very important point. Weight carrying, very crucial.
Yes. So Dr. Sharmini, to check with you, you mentioned earlier about the antegrade continent enemas where they put a stoma through the appendix. And you're quite right that we hardly do them nowadays. We don't like. Have you had any experience with transanal irrigation patients?
Yes, I do. For transanal, yes. So I have a couple with me now in my practice. So what they do is they have to, it's quite tedious, I have to say. And the patient really needs to be, I mean, obviously we will teach them how to do, and we will give them the equipment that they need. But it really takes a process about at least an hour to 2 of their time. But the thing is, they do not need to do it every day. So it might be maybe 2 or 3 times a week. So what they do is they put like a soft catheter in and they just put it in. And all they do is pour in a lot of fluid. So about 1 liter to 2 liters of water into the inner canal, into the rectum. And what tends to happen is it just softens the stools and then they just pass it out. It's a very messy procedure. It takes a long time. So you need a very dedicated patient who is willing to do this. And these are the patients who maybe either they refuse surgery or they don't want a stoma because they die want to keep their anus now, okay, whatever it is. So you can tell that these are the patients that are dedicated to do what they need to do. But the thing is, even though it is cumbersome, it is messy, and it takes time, they are happy because after 1 hour, all that work, they can do whatever they want. They can go out, they know that their bowels will not give them any trouble. They can eat whatever they want. So for them they are quite happy that, okay, maybe 2-3 times a week, and they know when they have to do it. They are willing to take that time to do that. So there's a group of patients who are willing to go through with you in this process. But it's a very safe procedure. Not dangerous, okay, because of course we will counsel them accordingly, and then and they know, if there's any problems to come back.
Thank you. If I were to elaborate a little on that, okay, so quite correctly that in many patients with severe intractable constipation, if we fail all medical therapy, we may consider surgery. And in the surgery, you either remove the colon that is no longer contracting well, such as a total abdominal colectomy, or if you do not want to subject them to such a massive resection, we sometimes just pull out a stoma. But then in the beliefs of many surgeons is we are exchanging one set of problems for another. Because one was severe constipation, but then if you take out all the colon, we run the risk, as you said, that the symptoms recur very quickly within 12 months with a long-term success rate of only 30%. And we now introduce the risk of intestinal obstruction to these patients who didn't have it before. With a stoma, there are stoma-related complications, cost of stoma management in the long term. So transanal irrigation basically is an extension of you using an enema. If you imagine a patient who has impacted stools, if you get a bottle of fleet enema, it helps to evacuate the stool. However, fluid given in the long term can lead to hypokalemia, and it cannot be used more than once a week without supervision. So instead, we use irrigation. Now, many of you in the audience may have heard of your patients buying the coffee enema kits, chlorophyll enema kits. They're all easily available. They will get through, they're illegal in a sense, but once you're true, right? And I have myself have had patients using this type of home enema kits. So one of our sponsors today, WellSpec, actually has the only HSA approved transanal irrigation kit available in the Singapore market called the Nabina. If you have patients whom you think may benefit from this for severe constipation, please refer them to the doctors in the hospital. In the government restructured hospital, currently the first one that's doing it, supervised by the nurses, is actually in Singapore General Hospital. I've spoken to the representative from WellSpec, and they are hoping to get the results from a study from SGH and then roll out this as a clinical service to the other hospitals as well. The data is extremely safe, but as Sharmini has said, it is tedious. But we must remember, these are not people who are passing motion normally once a day. These are patients who are suffering pain and already poor appetite from bloating. And then with all the pain in defecation, they might get hemorrhoids, anal fissures, and they only go to the toilet once a week. So in order for them to evacuate 3 times a week without problems is a significant improvement for them. Yet it doesn't carry the risk of surgery. So please, if you have patients with intractable constipation and they're not sure where to go, you may refer them to the various restructured hospitals. The one that's running this service is SGH currently, but all the other doctors in the other hospitals will know all the options available, or you can send them to the specialists in the private sector as well. And I think we have dragged on the time quite a lot. It's now about almost 3:45. I want to thank again all the speakers. I want to thank our 2 sponsors today, Tina and WellSpec, for your generous help in allowing us to organize this. And lastly, I want to thank all the participants who have stayed with us all the way until now and listening to everything we have, because we really want your help in ensuring that people with incontinence, with pelvic floor problems, are able to age in place with their dignity intact. Okay, thank you very much. Now, before we go, this is the most important slide I need to share with you. So the Society for, okay, I'm plugging the Society for Continence now. The society is, as I said earlier, fully run by volunteers. So we do need some help with donations if possible. We are an IPC approved charity, which means that any donation that you give to us then will have a 2.5 times tax rebate. So please open on your phone your banking app and scan the QR code with the Pay Now. In the bill, if you're going to donate to us, please in the reference, put down your name and your IC number, so that we can verify who you are in our submission to IRAS for your tax deduction. So I hope that some of you or all of you are willing to help us with your donations. Okay. And
Dr. Lim,
with that,
sorry,
yes.
Suddenly we have a question in the chat.
Okay. This person, okay. 11-year-old child passed motion once in 2 weeks, traumatized, even refused an exam. Okay, so there are different kits available for this transanal irrigation. In this case, I cannot give you a specific answer as to a child. What we can do, because in this case it's about psychological trauma as well as a management of constipation. Unfortunately, today among our speakers, we do not have a pediatrician. Most of us here are dealing with adult type conditions. But I can only tell you that currently there are 2 irrigation systems that are approved for clinical use in Singapore, one called Peristeen and the other one is called Navina. They do have smaller sizes, but actually the catheter is already quite small. It's smaller than the size of a stool of a 5-year-old child, a normal stool. So it does not traumatize anything. If you have a child such as that, then it's about whether you can convince the parent, I guess, and the child to give it a try, because they have to overcome the psychological barrier. And once they try it, then they can determine whether it is suitable for them. I hope that answers your question. So back to my plugin. So sorry. I'm going to leave this Play Now code there for about a minute. And I thank you all for your attention, and please have a good weekend. Thank you to all the speakers.
Much longer time than others. This means gentle catheterization and that the catheter doesn't stick at withdrawal. It's the key to less urethral trauma and urinary tract infections. And low-fric catheters have strong medical evidence to support long-term health. In short, low-fric's smooth surface has prevented pain and urinary tract infections for 40 years, and that is something to celebrate.